2. No. Oh, here we go. Oh. Right, let's try that one. Yeah.
What's this one?
Testing. They're lucky, you see. Probably get more points, wouldn't I? Testing. Yeah, we live. Okay, we'll have to go with that, I think, in a minute, and see how it goes off. We'll get the feedback. So, good morning, everyone, and welcome to this meeting of the Health Scrutiny Committee. Thanks, everyone, for being here on a lovely summer's day. Not so much. It's I hope that's not over today, but there we go. So, let's crack straight into the agenda. The first item is minutes of the last meeting held on 16th of April 2024. Does anyone have any comments on the minutes? Hannah, did you something raise?
Yeah, in the minutes regarding the work programme, I know it refers to Warsaw. Yeah. I believe our discussion was regarding Worksop Health Centre.
Well, if you get the 10 points, we'll see if I've read the minutes. You absolutely get the 10 points. And Bethany claims she read it as well, so I'll give her 5 points for that as well. So no, thank you very much. We'll make that amendment to it. So thank you for that. Any other comments on the minutes at all? No? Okay, so all happy to take those read with that slight amendment? Thank you very much. So 2 is apologies for absence. Martin. Oh, James, sorry.
I'll be doing it. So we've had apologies from Councillor Sinead Anderson for other reasons, substituted by Councillor Eric Carey, and we've also had apologies from Councillor John Maggie McGrath for other reasons, and substitute Councillor Pauline Allen. Thank you, Chair.
Thank you, James, and thank you, Pauline, and thank you, Eric, for something today and joining us today. So thank you very much for your time. So on to number 3 is declaration of interest. If any councillor offers any interest in any matter in the agenda, you should declare it now. And the type of interest, Michelle.
It's not an interest as such, but my father is quite known that my father is very ill, and he is very, very ill now. So if I have to leave the meeting suddenly, that'll be why. I didn't want anyone thinking anything otherwise. So
No,
just to make that clear.
Well, thanks to Michelle. So I'm hoping that all the best for you and the family. So thank you for telling us that. Anyone else want to declare anything for the agenda? No. Okay. Right. Thank you very much. So we'll go into item 4 on the standard agenda. So this is the Nottinghamshire Healthcare NHS Foundation Trust CQC filings. So as committee we asked this report to come to us based on the CQC reports that were obviously published. And so thank you very much for our guests for being here today to present. I know it's a very topical item, understandably so, and it's a very in-depth item, and it's got a lot of coverage in the press already, and it has a large impact on members of our community. So I don't want to go too much into that at the start, because I think it's really important we listen to feedback from obviously our guests here from the Foundation Trust, and then I'll come back at the end and say my piece, and obviously open up to the committee for asking any questions that they wish to do. So before going further, I'd also like to welcome Ifti Majid, Jan Sensia, and Diane Hull from the Nottinghamshire Healthcare NHS Trust. So thank you for being with us today, and hand over to you to kick off the report. Thank you.
Yeah, that button. Have I got that right? It sounds like it. Thank you very much, Chair. So I'm Ifti Majid. I'm the Chief Executive at Notts Healthcare. We want to talk to you today about the background to the quite unusual Section 48 review that was carried out into our organisation. I want to give you a summary of the various CQC and Section 48 recommendations. Want to talk to you about what we've done about that. Want to talk to you about our plan going forward, timescales, areas of focus. And then maybe at the end, I'll just come back and talk a little bit about other services and how we ensure that other services within our organisation maintain their focus, if that's okay. So that's the plan. The reason I want to talk to you about the background is that it is complicated, and I always have a worry when I'm talking to groups of people about this, that the information that you might read in the media is not necessarily the right background, and so I want to give you the background directly myself, if that's okay. So the Care Quality Commission, the CQC, visited Rampton Hospital, which is one of 3 high secure hospitals. It's up Repton way, and they visited there in June and July of 2023, and this was a follow-up visit. And in that visit, they found that there were issues with staffing, issues with the patients not having enough activities, that there were some issues around restrictive practice. So patients in a high secure hospital spend overnight confined in their bedrooms. Sometimes when there's not enough staffing, that confinement can leak out. They can be confined more earlier or remain in confinement later. So there were concerns about that. There were some environmental concerns, and I don't know if any of you have ever seen Brampton, but there are elements of it that are a Victorian building that need significant investment in capital investment in to bring it up to date. There was concerns about medicines practice, and there was some concerns, particularly in our deaf service, around communication. So between July and the end of 2023, we did lots of work, very successful. We might mention it later, around increasing our staffing, about reducing restrictive practices, about increasing the number of staff who were trained in British Sign Language. And this report from the CQC was published in January 2024, so it was published 7 months after it happened. And sadly, there wasn't the reference to the improvements that we'd already made. And that's important. So that hit the press and the various regulatory bodies in January 2024. At the same time, information found its way into the public domain about some checks that we'd been doing on staff in our inpatient areas and how well they were carrying out therapeutic observations. Therapeutic observations are an activity that happens to help keep people safe. So it's about me observing you and observing you closely in case you wish to do any harm to yourself or to anybody else. We found that some staff weren't carrying out those duties correctly. In fact, we found that some staff were falsifying records, saying that they'd done it when they hadn't done it. You would expect us to say that was a red line, and we suspended a significant amount of staff because of that. This found its way into the press in January at the same time as the Brampton report. And then, of course, also there was the court hearing for Valdo Colocaine, who was the perpetrator of the triple homicide in the city of Nottingham. And that was in the public domain at the same time. And this drew the attention of the Secretary of State for Health. I had a very difficult meeting with the Secretary of State for Health. And then that is what, those three things landing together, is what created the need for a Section 48 review. So Section 48 review is a review under the Act carried out by the Care Quality Commission at the request of the Secretary of State. There were three things that the Secretary of State particularly asked the CQC to look at. So they asked the CQC to look at available information that was in the public domain around Valdo Colocaine, his care and treatment for all organisations that he touched. And I just want to be really clear with you that this is a part review. So this review does not interview staff. It doesn't interview clinicians, leaders or managers. It's using the information that's out there, maybe information that was presented in the court case. It is different from what is currently happening, which is an independent homicide review, which is something that happens when there is a homicide linked to an individual with mental health problems. That is a very detailed review that interviews staff, it interviews leaders and managers, it understands policies, processes and what's happened. So that is ongoing. But in the meantime, there is this. There was part of the Section 48 was about reviewing information around Valdo Colocaine's care and treatment. There was also second part was around how safe are services in Notts Healthcare. Now it was initially set that broad, but actually it did focus down in the end on services that were that touched or could have touched touched the care and treatment of valdecocaine. So it tended to focus on community, mental health services, crisis teams, early intervention teams. And then the third part of it was, I mentioned that important 7-month period from when the CQC visited Rampton to January when the report was published. So the third part of Section 48 was, have the improvements happened that have been reported to have happened at Rampton Hospital? So that report was commissioned, and after that report was commissioned, before it reported, actually on the 1st of March, we had 2 further CQC reports that landed that we did know about, which were reports about our inpatient mental health services, both adult and older adult services. And again, in terms of total transparency, there were some really disappointing findings in those reports. For the older adult inpatient wards, there were concerns about observations around medicines management, around documentation, particularly risk and fluid and food monitoring, concerns about the environment, and some concerns about leadership. That was mirrored in the adult report as well, so concerns about observations and risks, some concerns about incident reporting. I think more than anything that was difficult, there was concerns about staff not always showing care and compassion. In fact, the opposite was true, and there was instances where staff were seen to assault patients, or some staff were seen to assault patients, and there was some concern about local management as well. So serious outcomes, and we had been talking to the CQC about this prior to it happened, before the report was released. So again, lots of work had gone on to improve the situation. So you'll be aware, because there was much publicity about the Section 48 coming into the public domain, which must be 6 weeks ago now, I think, something like that. And if you were to read the press around the Section 48, you would probably think that it was all about the care and treatment of valdecocaine, but actually the information that is in the public domain is not about that at all. It is about the second 2 component parts that I talked about. So it is about commentary about our community mental health services predominantly, and it is about commentary about Rampton Hospital. The part about valdecocaine has not been published yet, and we believe it will be published towards the end of June of next month. So the outcomes, and I'm not sure how many of you have read the report, but in the report there is commentary about our organisation. There is commentary about what you might call more strategic national issues in the mental health sector. There are recommendations for us as an organisation, but there are also recommendations for NHS England and for the CQC as well. So the issues I'm interested in, which is, what do we need to put right, is, there's high demand for all of our community services, and therefore there is a waiting list in our community services, which links to capacity. And there were questions about how well people on our waiting list are managed. So do we know consistently across the organisation if somebody deteriorates and needs more rapid intervention? There was concerns again about consistently, and that's an important word, but consistently our risk assessments and how we risk manage individuals. Is that consistent and clear across the whole of the organisation? And equally, do we engage with families across the whole of the organisation? There were some concerns about the spread of our community mental health teams across the county, or the county and the city of Nottingham and Nottinghamshire, and whether or not where the way the services were commissioned, they respond to needs of local people, or are they simply commissioned on a sort of per capita basis? The CQC also were worried about staffing levels. They talked about the staffing crisis in the mental health sector in the NHS, but of course we have our part of that, and we're aware of some of the risks to do with our staffing levels. And they also commented that whilst their view was that when something was pointed out to the organisation, we responded very quickly, very appropriately, but a question about whether we were proactive enough in our leadership. And they also felt that communication between pathways wasn't necessarily always the most effective. Now, they did recognise that these issues that I've just described to you were likely be seen in other organisations of our type up and down the country for the reasons I've described. And I tell you that purely by way of context, and it is not something that enters into the parlance of our improvement plan. We're not using that in a defensive way at all. We're interested in services that we provide locally. In terms of Rampton, which was the second part of the Section 48, they said that they had seen improvements. So they saw improvements in the number of staff who were trained in British Sign Language. They felt that patients were safer. They felt that staffing levels had improved. But they did say that they did note that many of the issues that had been previously raised had now been addressed. But they were concerned that sometimes therapeutic activities were cancelled. They were worried that when somebody had been medicated, that we didn't consistently look after their physical health in the way that we should be doing, and that we did sometimes still redeploy staff when there was a crisis, which we did and we do. Again, I think the big thing was, most notably, they said that there was some improvement in the culture at Rampton, but they recognised that there was a way to go. So, as a result of Section 48, as a result of the quality issues that I think it's fair to say have been emerging for a number of years within the organisation, probably linked to the scrutiny that the organisation is also getting nationally, it was agreed that we would move into something called the NHS Oversight Framework Segment 4, and therefore we would enter the Recovery Support Programme. And this is basically a system of oversight that NHS England uses for NHS trusts. And this level 4 is those trusts that require mandated support. So that means that we have an improvement director allocated to us. We have the opportunity for more money allocated to us. Where there are programmes happening nationally that they might help us, we get priority access to those programmes. One of the things we have to do, which we're now going to talk to you about in a minute, is we have to create an integrated improvement plan that deals with these issues sustainably, and it's based on that we would then exit this oversight framework level 4. And I think that going forward, it's probably our integrated improvement plan and the various segments of that we'll describe to you, which will give you the best opportunity to scrutinise us on an ongoing basis, so we can talk to you about the improvements that we're making. So I'll probably stop talking, because I think something that is really important is that we explain to you, or are clear to you, that we haven't waited for the Section 48 report to land. In fact, as a relatively new executive team, we were recognising these things prior to this, and we started to take action about it prior to that. And Di is our chief nurse, and she will just talk to you a little bit more about what those improvements already have been.
Thank you. Well, that's right. So, as Ifti has said, the Section 48 and the CQC reports in the main refer to 3 or 4 areas, and I'll try and put that into some order around our improvements. So, as I talk about the improvements, there's a genuine acknowledgement that there's still more to do, but an absolute commitment to continue to improve, particularly for the communities we serve. So, if I talk about local mental health teams, and I'll start with people waiting for our services. We have seen a 9% fall in people waiting for assessment, and that's been very much around the work we've done in really understanding what people are waiting for. Making sure that there's comprehensive assessment at triage and that we fully implement the waiting well policy. And what the waiting well policy means is that we do that really good assessment at triage. We give people information, details, where they can go if they need additional help. But also then we contact people regularly to see how they are. So we're not leaving people waiting. We put that safety plan in place around if you need services quicker, then this is who you contact. So we're in regular contact with people. We have seen a 30% reduction in out of area placements, which is a really good thing because we know that people, if they need inpatient care, the closer they are to their families and their friends, the quicker that they will recover and their experience will be better. In addition to that, it's not just about those numbers, it's about ensuring that the quality is right. So we've put in a robust quality oversight framework for those out of area placements. And what that means is that anywhere that somebody goes has had a quality assessment. We are in regular contact with people who are in out of area placements. If we have their permission, we are in contact with their family, and at the end of their placements we will be contacting them to find out again about the quality of the placement. So it's all about experience and all about the quality. That is something we didn't have before. So we don't want people to feel that if you're not in one of our services, we are not thinking about you, we're not caring about you, we're not in contact with you. And that is what the quality oversight framework is about. We immediately put in, increase the leadership in our local mental health teams. So we have an additional 2 leaders who really understand mental health care in the community, and they're working hard with the teams to improve not only the waiting process but the interventions that we can deliver. And we're seeing, as you can see with the fall in people waiting for assessment, people being able to get support quicker, but also being able to be discharged to primary care in a much more timely way. So if you think about inpatient services, we've done huge amounts of work, and we started that work, as Ifti said, before the CQC inspections. So observations, therapeutic observations, as Ifti has said, 3 levels. One is general observations, everybody's on that. The other is intermittent, where people might have 4 contacts in every hour with a nurse. And then there's enhanced observations. So really, really important. And it's not only about safety, and it's not about ticking a box, it's about making sure that we connect with people, we engage with people, and that we are aware of their needs and that we can escalate levels of observation at any time. So things that we've done, and we did immediately, was we reviewed the policy. So it didn't look at the process, but it looked at the privilege and the purpose of observations. They are a really, really important intervention. They keep people safe. We have reviewed our training, and our training now is over 90%, and that was very much again about the purpose of observations, not about ticking the box, but at the focus on engagement and participation in keeping people safe. We have a robust governance oversight process in place, so we review our observations in a triangulated way. So we're looking at the documentation around observations, we're talking to the people who are being observed, and we're using CCTV to monitor that. We currently have over a 97% compliance rate with observations, and we have many wards who are at 100%. We have an observations collaborative, and that's really important too. And as you can imagine, we're focused on the areas where there's been the most concern. We've done an in-depth diagnostic, and now we're working with using a QI approach to think about what other change ideas can we make with the people who use our services to improve further. I just really want to say that it's, and I'm not kind of excusing anything in any way, but there is a national problem around observations, and we are part of national groups around how do we improve it, because it has become very much process driven instead of people driven, and we are kind of leading the way on this work now. Other things you'll see in the document is real focus on physical healthcare, and use training is at 96%. Really important in older people's services that we have staff who are trained to identify the early signs of people who are deteriorating and take appropriate action. We've also done lots of work around falls, because in the CQC report they highlighted those, and so we have our falls experts who now work clinically to ensure that we are supporting staff to use the right interventions to prevent that. We've strengthened leadership, particularly nurse leadership in our inpatient areas. So we increased the heads of nursing in inpatient adults by 1, and we put an additional head of nursing into our older adult services, supported by rapid improvement groups, so that we can continually monitor those improvements. And we really believe that having people with the right expertise and the right leadership who are working clinically is beginning to show signs of improvement. We have, if I talk about Rumpton a little bit, we have seen a real increase in our recruitment, particularly of nurses. We are regularly at 100% fill rate and above if there's enhanced observations. We have more nurses who are starting in the summer, newly qualified nurses, and it is becoming a much more attractive place to work. And that has resulted in real impact in morale and culture. But equally, we're hearing from patients, people using the services, about the difference it's making to them. And that's the most important thing, about the ability to have really trusting relationships, have people who can support you with your care plans. We've seen a real increase in training as well, as Ifti said, but that has been sustained throughout. And the reports identified confinement issues. We have seen a real improvement in that. In fact, it is something that only ever happens if there is an emergency, and an increase in our activities as well. I'm happy to answer any questions at all, but most of it is in here, and I'm happy to go through any figures. Hand to Jan. Or is it back to Ifti? Sorry.
No. Jan, just pick up and talk about the integrated improvement plan and the future plans.
Thank you. So, Jan Sensia, I'm Director of Partnerships and Strategy, and my job is to work with all of the parts of the organisation to put together an integrated improvement plan, as Ifti said. I think one thing that I should say from the outset is we know we've got a lot of short-term, medium-term and longer-term actions, and we need to put those into a really coherent framework. We need to make sure that our plan is addressing some of those root causes that Ifti and Di have spoken about. So what we did immediately was to identify what are the key themes that are coming out that address those root causes. And as a result of that, we've set up a plan which has got 5 key programmes within it. The first one is around quality and patient safety, and Diane is leading that programme. And that's really looking at some of those quality issues that we need to tackle. We also understood that there was a real issue about both leadership and also some of our operating processes. So we've got a programme we call Leading for the Future, which our Chief Operating Officer is leading, and that is looking at some of those issues around investment in learning, investment in training. One of the things that we've recognised is that maybe through COVID some of that dropped off, and we really need to invest in our leaders to help them take forward very difficult jobs in very difficult circumstances, but also that we have not got consistent processes throughout the organisation. We haven't got the frameworks that we need everywhere, so we've got a whole project within that looking at making sure that we've got that consistency, and that was one of the things that very much came out of the Section 48 report for our local mental health teams. Then the third programme, because what we haven't touched on so far is that alongside these quality challenges, we also have some financial challenges as an organisation. And for the first time in many years, we posted a deficit position at the end of 23-24. We know that we have to do some work to be able to bring that deficit down in the current year. So we have a finance and productivity programme that is tackling, although it's called finance and productivity, it is tackling some of the, again, root causes behind that deficit position. One of the things that is a root cause, for instance, is on our use of private sector beds, and the amount of those that we've used over the last year has grown quite rapidly. We know that we need to bring that down. We know we need to manage that better. And so that is within that programme, and Di's already said we've already begun to see that decrease, particularly in the out of area beds, which is good. And then the fourth programme within our plan is on people and culture, and that really again is back to that investment in our people, in not just in leadership but in people throughout the organisation, and tackling some of those cultural issues that Ifti touched upon, and making sure that we really set the right culture throughout the organisation. And then finally, we have a programme on governance, because we need to be well governed as an organisation. And within that programme, we look at our systems, our processes, our work on assurance, but also we look at things such as, for instance, we have a very large investment coming into the organisation this year to improve the way that we use our digital electronic patient record systems, and that also we need to make sure is really well spent and really well invested to improve how we work. So those are the 5 key programmes within our plan. What we have done over the last few weeks is to recognise that it's a huge plan. It's going to take a long time to really tackle everything that we've got in there, and some of those ambitions that we've got in the plan are long term, because you don't change a culture overnight of an organisation. You can't turn that oil tanker around quickly. But equally, we have some really, really important immediate actions that we need to address. So what we've done with the plan is to reshape it into phases. And phase 1 is all about tackling the recommendations in the Section 48 review, tackling some of the additional relicensing requirements that there are for Rampton, because we have a relicensing system for our stewardship of Rampton. And then the third element is around our financial recovery. And that will be the first phase. We're not losing sight of the longer term things, but we're making sure that the phases all link together, and that what we're doing now in that first phase with those immediate actions is also investing in work that will help us in the second phase, and hopefully as we come out of the national oversight framework that Ifti talked about, and head towards sort of the sunny uplands, that will be our third phase. Each of our programmes has as its lead one of our executive team members. So I've described Di's role, for instance, on quality and patient safety, and we have set up a programmatic approach to delivering this. So we do have a central programme management office. We're getting a lot of advice and help and support from our colleagues, both in the system, the ICB, but also from NHS England colleagues. And we will have supporting the overall portfolio board, which Ifti chairs. We will have, because we're very determined to get these voices heard, we will have a staff reference group and we'll have a patient reference group, and they will be really important. We're also trying to be very open and transparent in the way that we deliver this programme, so we will have some external people on the programme boards. For instance, we've been talking with Healthwatch, our ICB colleagues will support us as well, and we'll make sure that we're really open and transparent in the way that we deliver those changes. So that's what I can't do at the moment is share the full plan with you, because we're still going through the final processes of that, but that gives you hopefully a good outline of what the programme will look like. Thank you.
Thanks, Jan, and we very much welcome the opportunity as that becomes finalised to come back and show you in more detail the plan, and I think the expected outcomes and the metrics that go with that, so as to show how we know that things are improving. Just one last thing I wanted to share before we stop talking and take any questions is. Just to remind you that we're a large organisation, so about 10,000 staff. We make about 2.5 million contacts with patients a year, and our services are much wider than the services that are in focus in the media at the moment through the CQC reports and the Section 48. We deliver, CAM services, specialist physical health and mental health services, forensic services, community health services, including community nursing, healthy families, SEND response teams, and we have 2 hospices as well. So I wanted to reassure you that the focus of our organisation on those other areas, who are often good, they are good in terms of CQC ratings, absolutely continues. One of the advantages of us being in NOF 4 is that we get extra resources, Oversight Framework 4 is that we get extra resources coming into the organisation, which means that we don't need to pull from other areas to try to service improvements. I also believe that our care group structure, both at a strategic level but at a service delivery level, is set up to make sure that individual services and individual service lines get the right expertise, both clinically, operationally, and also get the right corporate support. What I would say to you, though, there is an opportunity to learn, and one of the mantras that over the last month or so we've been putting into our organisation and talking to people about is that, if you are sitting in a community nursing team up in Bassett-Law, we don't want you ignoring the Section 48. We want you to have looked at it as a team and to be saying, well, what lessons do we learn from that in the way that we operate? And that feels really important because we need to share that learning throughout the organisation. It's as important if you're waiting for a therapy assessment in the community because you've had a stroke that you wait well. It's as important as if you've got a mental health difficulty, and we recognise that. And our governance structure in the organisation does, our performance management structure is not predicated around the Section 48. That is part of it, but it is much wider. Our integrated performance reporting reports across all of the services across our organisation, so we can see that performance in those other services is not being impacted. And I suppose just some examples that you'll be aware of. So in the Healthy Families team, we're meeting 4 out of the 5 targets. Granted, one of them slightly dropped in the last quarter, but we are meeting things like the breastfeeding targets and the targets at 6 weeks. I have to say there is a very impressive waiting list management programme within Healthy Families. Referrals are seen. All of our referrals are seen within 2 weeks. 93% within a week, and the majority of people seen within 11 weeks. And in terms of SEND, so I sit on the SEND board, and we have a new governance process in place, so as that I get really clear reporting. It's part of our reporting to our board of directors. We have an increased number of people who are trained around the SEND agenda. Our EHCP, so our education, health, care plans are now at 96% compliance at 6 weeks. So we have made big strides forward, and they continue whilst we have the focus on the improvements that we've previously talked about. So I'll probably stop talking at that point and pause and take any comments or questions.
Okay, well, thank you very much for that comprehensive report and update, and the amount of detail you're going to is appreciated, and I think answers quite a few of my points I had, to be honest. I'm sure other members, but I suppose for me, having read through the reports, it was quite harrowing reading. I'm sure it was yourself. I'm sure for anyone who has read them, and one key thing was around culture, and so I was glad that when you mentioned about it in terms of understanding that, and it can't change overnight, but it's about putting the blocks in place as soon as possible to make sure you change that. If there are, the reason we brought this to committee, I think, was to understand where we currently are as a service and make sure that if people are needing your service today, tomorrow, that they have confidence that they're going to get the treatment they need. So I know you talk about culture so far, but what assurance could you give to people who are watching this now, who think, oh, I'm apprehensive about coming to use services that you provide, that they are going to get the treatment that they need and deserve?
So, Di, I'll bring you in a minute just to talk about Safe Today. But so the issue about making sure that when people are vulnerable and they need particularly mental health interventions, that they feel confident to seek treatment from our organisation is really important to us. And so one of the things that we have done is develop something called the Safe Today dashboard, which is an at-a-glance dashboard that tells us how we're performing against some of the key issues that could define whether somebody's safe. So things like how long people are waiting for, things like whether risk assessments are in place. Di, do you want to just pick up a little bit more information about that? Because I think that's one of the main things that we use to check people's safety.
Absolutely. So the Safe Today dashboard has a number of indicators that would identify not only safety, but think about, are there any early signs of an area that's struggling? So they kind of give you oversight but confidence around safety as well. So the things on there are around staffing, complaints, compliance with observations, stuff around restrictive interventions where seclusion's being used, whether segregation's being used. There will be things around number of people in seclusion, number of observations. There'll also be information around people waiting, how many people have had the waiting well calls, how many people are waiting for first assessment, how many people are waiting for treatment. The most important thing about that is the triangulation and looking at, is there any specific areas that we should be concerned about? And that allows you to be really proactive. I think it would be important to say that that's supported also by quality first visits. So we're not waiting until something gets really, really bad. Early signs, quickly go in and support and help and understand what's happening and think about the things that we can do immediately to improve things. So we've developed that with the ICB. So it's a collaborative approach because it is for our communities, and it will be something that we can continue to develop and that we can kind of define some more support interventions as well. But it is working well. We are presenting it regularly. We're having meetings with the ICB weekly, and it has enabled us to really understand from that triangulation methodology what's happening in each of our areas and each of our community teams. So it gives you an at-a-glance oversight, but you can dig deeper into it to really understand. The bit that I think is really important is picking that up and talking to people. And I don't just mean staff. I think it's important to talk to the people who use services and their families to understand not only what's happening, but how we can improve together. Because I think that is what's going to make the improvement sustainable.
And I think you touched on a really important point there, Di, because I think if you, and this is no criticism of people who have led the organisation previously, but I think if you look at our response to feedback from organisations like the CQC, historically we have tended to respond in an action-focused way to the specifics, rather than thinking about what's the root cause and how do we make it sustainable, and that's what we're doing differently on this instance.
Thank you very much for that, and I think I'll come back in. I want to bring in other members of the committee first. Thank you for that. So, Bethan, then Steve afterwards.
Thank you, Chairman. Thank you for all the information that you've just given us. I'm really glad that you've got people and culture as one of the programmes that you're doing. And my question is around staffing. We know the NHS staff are really important and they do amazing things, but how are you going to make sure that newly qualified staff after straight out of university, have the experience, have the knowledge, and have the support and training to make sure that they can work well and comfortably. I know preceptorships are something that they have to do and take place, but how are you going to make sure that they are supported in the way that they need to be? And also, I think ongoing training and development with staff, and it's really scary when you say records were falsified. Like, that just makes me just go, ugh. It's a really scary thing. That how will you ensure that that won't happen again? And is there any way staff can report something if they see something happening? Because I think that's one of the major things. If you, because someone must have known that was happening, and why wasn't it reported sooner? So it's more, how do you make sure everybody is working to the right guidelines?
Sorry, I forgot to put my microphone on. So, preceptorship. Something I was only discussing yesterday, actually. So we have lots of new nurses coming through, and they're our future, aren't they? And they're full of kind of energy and ideas, and we have to look after them. So we do have a preceptorship package, but I'm not sure that's quite enough. I think we need to think more innovatively about preceptorship. And one of the things we've been discussing, and we are speaking to universities as well, is around that final year in your nurse training. So if we interview you at the end of your second year, tell you where you're going to work, in that final year, you can almost begin your preceptorship whilst you're training. So you can do your final placement in the place you're going to work. We can help you access some of our in-house training whilst you're doing your training as well. And you can start that relationship with your mentor. So that is something we're going to put in place. We spoke yesterday about strengthening the preceptorship, again, not just being task orientated, particularly in our mental health services. So spoke about commissioning some co-facilitated, co-produced training, which really focuses on the art of engagement, because I think that's the bit that people really struggle with. We've also putting into the programme the things that I know from speaking to newly qualified nurses are really important, that often get forgotten. So the things like, how do you coordinate a shift? How do you work with maybe people who are in your band threes, who really want to, who think they run the ward, but you're taking responsibility for it? How do you do your delegation? How do you always hold the patient in mind? But also thinking about some of the complexity and acuity we're seeing. So we're seeing a lot of people who've had trauma in their lives. And I think that often people struggle, because of the whole transference stuff, to care for people with those kinds of presentations. So we're looking at trauma-informed care as part of that. We've commissioned STORP training as well, which is part of the risk assessment, so that everybody can have access to it. So I guess what I'm trying to say in a roundabout way is the preceptorship package will include training, it will include individual and group support with action learning sets, with a real kind of focus on wrapping a cloak of support around people. We have got the Band 5 to 6 programme as well, because we know a lot of newly qualified nurses, and I understand why, really ambitious and want to get to a Band 6. But we need to think about how we're going to do that in a supportive way. And then the other thing is around our structure. So we've had, as many places have, a traditional structure, which means you're a Band 5, and then you go to a 6 management, and then you either go into an ops management or a clinical kind of pathway. We are creating more clinical Band 6 roles, more clinical Band 7 roles, with an aspiration to have more nurse consultants as well. So really bringing back the expertise and the experience closest to the patient. So at the moment, our ward managers, our matrons, our heads of nursing and our lead nurses all work a clinical shift as well, so that they can be alongside our newly qualified nurses, because we know that newly qualified nurses want to feel safe, they want to belong, they want to have people with the expertise as role models, they want to be part of something innovative, and they want to have the opportunity and the time to do what they train to do. Those are the things we're doing. and it's really important. One last thing, because it is important to me, is there's something also about developing the role of the unregistered nurse. So we're looking at what a band 4 would look like. Could we introduce things like life skills recovery workers? Could we think more about expanding our peer support work network? Thank you.
Just two other bits that you mentioned. So I'm a mental health nurse, and I too found it really, really difficult, and quite frankly couldn't quite understand why people would falsify records. And this is some of the conversation that we've had, and on record I take a really strong stance about it, because we're talking about people's safety at the end of the day. Your question about speaking up is a really good one, and actually I think as we have started to roll out and be really clear about our expectations and the quality standards that we expect, people are coming forward actually now and saying, I've seen this, and can you do something about it? And the last thing I would say about that thing about how we value colleagues, because we value colleagues not just by giving them a job, but by giving them a sense that they can own the job, and that they can influence their job, that they have a voice, that they can speak up when things aren't working and be proud when things are working, and that their efforts are celebrated. And actually that's the culture. So when we talk about culture, it's that culture that drives speaking up, it's that culture that drives improving care. And I think it's that there is a reset that we're trying to bring about that says we're here for one thing, and that is to improve people's lives from the communities that we serve. That's why we're here, and there is it's not an immediate fix, but this is the thing that is going to give us the sustainable long-term change, which is bringing everybody behind that reminder.
All right, thank you, Bethan. So, Steve.
Thank you, Mr. Chair. I must say at this stage, I'm hearing an awful lot of management speak going on, and it doesn't impress me, I'm afraid. For 37 years, I was on the end of it. It didn't impress me then either. Section 48 review, initiated by the Secretary of State, is an extremely important issue. An extremely important issue. And I hear this, that it's in the past, but it's in the very recent past that this has all come to light. The very recent past. It's not 2 years ago, 5 years ago. These are very recent reports. And just one of the things that springs to mind here is that leaders were aware of the risk and issues faced by NHFT, but action to address safety concerns was often reactive. There have been a number of changes in leadership in recent years. While leaders were aware of some of the current risks in safety and quality of services, they did not appear to have clear oversight of these. NHFT was taking action to address safety concerns, but these activities were predominantly reactive. It's great that we've got a plan to put these things right, but we should have had that plan before, because somebody knew what was going off. It's quite clear we should have had that plan before, and there is clearly a lack of leadership here. It's plain as the nose on your face. There's a lack of leadership here, and just also the quality of care and treatment across the trust varied, and care provided did not always meet the needs of the individuals. Has that changed? I'm not convinced this morning that it's changed, or that it is going to change because of the factors that have already been mentioned. And just very briefly, I'll share an experience I've had as a county councillor in my division, and I'll be very careful not to give out addresses and what have you. But I was phoned by several residents one morning at the man at a certain address, was all walking up and down the road in his underpants shouting, and now he was on the roof of his house. He was known to have issues with mental health. He was on his roof for 6 hours before they managed to get him down, and he was taken away. Phone call the next day, oh, he's back in the house. So I phoned and said, why is he back? Oh, he's no threat to people and he's no threat to himself. The next day, he did it again. So I am not convinced that what is being told to me is going to be enough to actually put this service right. I'm sorry, but that's what I think. I think what I've read and what I've heard this morning.
Okay, well, thank you, Steve, for points. Obviously, raising that. I think if you could give some commentary on, obviously, on what Steve said then, some assurance, and which obviously Steve come back on that, we appreciate. Thank you.
So first of all, I apologise to committee if I've given or if we've given the impression that we are saying to you these are historical issues. They're not. So let me be absolutely clear. I agree with you. These are current and present issues. These are issues that we as a leadership team own. What we recognise is some of the roots are historical, but that doesn't change the fact that we have an accountability and a responsibility today to move these things forward. I do remain convinced that the approach that we're taking around our improvement plan, some of the evidence that Di has given you already about improving people's, how long people are waiting for, improving our oversight of people when they're waiting, improving our risk assessment processes, they are making a difference. I'm really sorry I can't comment on that individual clinical case that you mentioned. What I would say is that we have evidence that our crisis teams, for example, are responding more quickly to individuals when they need help and support in their communities. We know that when people are presenting in emergency departments with mental health problems, we know that we're responding well, and we know that we have one of the best liaison teams that work with the police to go out and address the sorts of issues that you're describing in the country. I mean, our liaison service is extremely strong indeed. So I think that we have got in place the things that will bring about an improvement in mental health services for those who need specialist secondary services. I think that's absolutely right. I think there is a way to go. I also think there is a way to go in how we involve and engage local communities, how we involve people that maybe don't meet the requirement for secondary mental health services, and how we ensure that they have the services that they need in their local areas. And I think that is part of the longer term sustainability of the partnership work that we're doing as well. What I'm quite happy to do and would welcome the opportunity to do is to take specific parts of our improvement plan and come back and talk to committee about them, giving you the absolute detail. And of course, we're also very happy if you feel able to share with me the details of that individual incident outside of committee. We can look into it and come back to you and give you some more information, and we're always happy to do that as well.
I think a key one will be when you're considering how you engage going forward is you have got good resources in the community, such as counsellors. Steve's given an example there, who are close to the community, who understand that way. So having that direct link as well into, or having that opportunity for counsellors to feed into a direct line that will give you that feedback, I think will really hopefully help, and also to understand and reassure the community. Because again, as counsellors, we do have that links in there. We've got people come to us out there. So if you're getting a clear message out from counsellors, say, I've raised it, this is the culture there, it will do a lot, I'm sure, to the wider community to get that reassurance. So thank you very much. John, Councillor Wilmot.
Thank you very much, Chairman. Thank you, all three of you, for a very thorough report explaining the problems in the services to Rampton. It must have been a very difficult situation for you. My first thing is that, correct me if I'm wrong, you said that you'd not consulted the staff on the report. Because I would have thought that was one of the first things you should have done, as they are in the engine room of the service and must know what the problems are. And of course, is staff training being reviewed? Because that seems to be one of the big issues that is taking place. In my time as a councillor, and it's a long, long time, I've never seen a service that needs so much improvement. We are, unfortunately, letting down some of our most vulnerable patients, and this is a badge of shame for this county. Considering that mental health issues are an ever-increasing problem all over the country, it is disappointing that there is a continual problem with these services at Rampton Mental Hospital. The review shows many unacceptable shortcomings and the lack of appropriate care being provided. It is a damning report, with the lack of leadership highlighted in the report and a lack of communication around services and the problems with the quality and safety of care provided. The question is, another question, does the NHT understand the problems led to this inadequate performance, and how long will it take to be able to address the problem areas? I'm sure the committee will want to be assured that your plan will show the necessary improvement in the services without diverting resources from other areas of the services. And I'm sure this committee will also want further updates because of the serious position of mental health problems at Rampton and, to believe it or not, all over the country. Now, looking at the Care Quality Commission's inspections, the findings are very, very serious. If the patients had not gotten enough problems, it is clear that the service that they were receiving is unacceptable. It's inadequate, that overall working age adults and older people were receiving poor care. Now, looking at the special review commissioned by the Secretary of State for Health, the report says patients and the public were at risk of harm. The quality of care and treatment did not always meet the needs of the patients. Patients were not always being kept safe, and leaders were aware of the problems, but action to address the issues were often reactive, which has already been said. It also states that the communications between services were often poor, which affected care for people, and changes were not happening quickly enough. Now, the Trust's response, it's encouraging. It is encouraging, there's no doubt about it. But, to be honest with you, it is too late. And that is why it is essential the improvement is monitored by this committee. Overall, Chairman, I hope that some of these problems can be addressed very quickly, but I don't know whether it will happen. Thank you very much.
Okay, thank you, John. And there's a few points in there, but if you could come back on those, appreciate
Thank you. First of all, can I? So I'm sorry if we gave the impression that we haven't consulted our staff. That is absolutely wrong. So prior to any of the reports coming out, our staff were consulted. They were spoken to. They were supported because staff have found the process very difficult, as you would expect. Now, if I can come to Rampton Hospital, as I was saying, if I could remind you that the inspection that is the subject of that report happened 7 months ago, and there have been very significant improvements in the care and treatment at Rampton Hospital, as the CQC themselves recognise in the Section 48 report. So actually services are already improving, and there is evidence that services are improving at Rampton Hospital. That's not to say that, I think I was describing, that we have, in order to make those changes sustainable, we need to make sure that it is a place that staff want to work, that it's able to retain staff as well as attracting new staff. And I think that since the CQC inspection, there have been 70 new nurses and healthcare assistants, with 20 more that Diane was referencing starting soon. So we clearly are now starting to attract staff to Rampton, and that only happens when the improvements are seen to be working. So I think that the actions that we're taking are bringing about a difference for those very poorly people in Rampton that need our help and support. And I think that the evidence from the Section 48 is that is the case as well. I'll probably stop talking at that, Chair.
Okay, in fact, I think it's really much acknowledged the fact that there has been a time since that report was done and the work you're doing towards it. But around the staffing, I do have to agree with John to look at the report. What you just said there isn't really reflecting the report, and that's what we need to look at in terms of work with staffing, because I think what we've seen particularly with NUH is the way they've been very open with the staff to go, we want to come forward, to really, and encouraging that very precipitously, and that does really improve the culture. I think when staff know that they can come forward to it, because also Legal eyes and ears, so they're going to know. I think my experience in managing staff for over 20 years is they probably know what goes on than I ever did. So actually, I'd always speak to them and encourage to go, what's your view on this? How do you see that? Because one, not only are they feeling important, but two, sometimes it's something you've missed. So I suppose that for me would be building up point, John, about how we make that clearer. I'm sure you are telling staff, but that's not really reflected to us and perhaps the wider public. So how that can be reflected reports going forward, but also that assurance that is what you're looking to do with the team, because I really think that would have a huge difference with the culture.
Perhaps I could just say a word on that in terms of the plan. So we have developed the outline and the framework of that plan, and we do know the projects that we need to tackle to make the improvements. But we've done that through obviously discussions with staff, but we're doing a much more engagement over the next month. We're having something we're calling the big conversation. We are a very large organisation. We operate out of over 200 sites, so getting around to all the staff is we need to have a proper formulation to be able to do that. So as I say, you brand it as something to be able to get that engagement. We're branding it as the big conversation, but we're going out with the plan. We're talking to staff and we're asking the staff, how do you think we should be taking this forward? How do you think we should be implementing this? What do we need to do to make this work? So I just wanted to reassure that we do have, even with regard to, we're trying to build in that staff engagement into staff and patient engagement should be everything we do. Should be around that, and that's why we've got the staff reference group in the plan, but also we're doing this big conversation. Thank you.
So we've got Michelle next, followed by Nigel. Thank you.
Hi. First of all, thank you for coming. And one of the things that I found quite refreshing is the last time that received knowledge of something that was to this level that was happening, we didn't get the level of what I think openness and transparency that you've come with us with today. So that is for me, that is a step forward. The report within itself and the CQC report, without repeating other people, makes a pretty harrowing read. And I think we're all in agreement with regards to this in the room. And one of the things I think which is felt acutely, especially when you're a counsellor working in the community, is not just the impact of that person that is suffering, that's bad enough, but it's the impact when that person is suffering, doesn't get the right treatment, not only on that person, but on society as a whole. And I'm not going to go into that in too great a deal. I personally don't think a certain person's name should have been mentioned in this report, given that the case is still under review and there are legal implications with regard to that. That name shouldn't be in here. But we've seen some of the worst case in Nottingham that devastated us as a city and as a county as well. But on top of that, we hear cases. I'm an accompanying representative for a trade union, so we hear cases of people that have suffered from mental health, that aren't getting the support that they need, that go into a supermarket unshop and are violent and aggressive towards people in there, violent and aggressive towards paramedics, violent and aggressive towards police officers, violent and aggressive to frontline services in public services. So the impact of when we don't get it right, not only on those people that are suffering, but on society as a whole, people walking down the street, all of those kind of things in workplaces. We know how vulnerable people can be in supermarkets, etc. The impact is just so great. And that's why actually this report and getting it right with the work that you're doing is actually a big societal thing. It's huge. So I personally believe that what has happened is wrong. Okay, I do. I think that is wrong. I think some of this should have been picked up before. I also think some of this is because there is a national mental health crisis and actually those early pathways have been eroded away. And I think we need to have a wider conversation about that. And that's been going on for quite a while, because I know that when I worked for a member of parliament, which was quite a few years ago now, that when the call came in for someone with mental health, that pathway to the point where we get them the support that we need, that early pathway has been completely eroded away. And what happens is we come with high intervention, which is you, and you became inundated with people that you are trying to fix, that if something had happened a lot earlier on, would be in a lot better place and perhaps not on your doorstep. And that's fundamentally how I feel. I feel that you are massively up against it. I'm not defending anything that's happened within that report, but I am acknowledging that, and I think there needs to be that wider conversation I've got a couple of questions that I'd like to ask before I move on to what I'm saying, if that's all right, Chairman. We've talked about culture. What is that culture that you're talking about that wasn't right within your work, within that workplace? That's the first thing. And the second thing is, when we talk about falsifying records, what do we mean by falsifying records? Because that could cover, you know, a lot of things. But was there a pattern in that falsifying records that caused that huge problem for them to say that? Because I think that's quite important for us to know. That needs to be dealt with and fixed and sorted, you know. And I know what you're saying, we're doing it, but we need reassurance that is really doing it, because I've sat in room with patients in a different department with healthcare trusts where records are falsified, and the impact that that has had on victims and people is utterly horrendous beyond belief. And what happens to those people that have falsified those records? That's also what I want to know as well, because as I said, the impact of falsifying a record on that victim and society on a whole is absolutely huge. So if we could just get some clarity on what is that culture that you're talking about, and what is falsifying records, and what happens to someone when they are found to be falsifying those records, that'd be great. Thank you.
Di, if I come to you for the falsification of records and some of the details. So just to respond to your other points, I absolutely agree that the impact on people with mental health difficulties not getting the right care and treatment at the time that they need it impacts on their families, and it impacts on society as well as them. I think that's absolutely right. I suppose, given the fact that we're in public, I ought to say that the vast majority of people with a mental illness aren't violent and aggressive and don't demonstrate those traits and live very well in the community. I think it's important that we say that. In terms of the culture that you ask about, I think that there are 3 or 4 elements, and of course everybody knows that there are cultures that pervade across the whole organisation, and there are cultures in individual teams as well, and they can be different sometimes. But generally, I would say that our organisation tended to operate in silos. It's a very big organisation, and therefore didn't necessarily communicate or talk across some of the teams or some of the ways that we organised ourselves, and we have done a lot about that. I think the culture of learning in the organisation wasn't strong. So when things don't go well, it's really important that we, in a non-defensive way, have conversations about what might have been done differently, what would have brought about different outcomes, what would have improved somebody's experience, what would have meant that these individuals or staff didn't leave the trust. So I don't think we were as strong on that, and I think we tended to be internally looking rather than externally looking. So one of the things we're doing at the moment is, and have been doing for the last year, is embracing people coming into the organisation from outside specialties to give us a different view. And that really changes the culture, because you're bringing people in. Equally so, if you promote people from within, you propagate the culture. If you bring people in from outside with expertise and skills, it starts to change the culture. And I think the last thing I would say about the culture is that and I mentioned earlier that it tended to be task orientated. So, and I think this is really important, because I remember the change that I went through when I was clinically nursing, which was, the traditional thing about being a task orientated nurse, which would mean that you in effect go around with a clipboard and you do various jobs. And actually we changed that, didn't we? Because we changed that to being about being focused on individuals' needs, focused on patients, focused on their families. And I think, this gets to the crux of what we need to change from the culture perspective in the organisation, is that we are not here for the future of the organisation. We're not here for the officers of the organisation. We're here for the people that need to use our services when they're at their most vulnerable, and that is what we need to focus on. And I don't think we have been as good at doing that as we should have been, in all honesty. So those are the cultural things that we're talking about, and those are the cultural things that we're trying to change. change. In terms of the falsification of records, Di, do you want to just give an update?
Absolutely. So just to give you some detail, so those 3 levels of observation, general observations, those are the hourly ones, intermittent, where people could be seen 4 times in the hour, and then the enhanced observations. We've had no episodes of falsification with enhanced observations because you've always got somebody with you. It's those intermittent and general observations. And so what people have done is said that they have seen someone and recorded that they've seen someone, and they use an iPad to do that. It's like EOBS, it's called. They've said they have. We do our checks and we can see that they haven't. But equally, what we've seen lately, and I think this is because there's been such a focus on it, and I lead the collaborative in observations, I'm a mental health nurse, that people are coming forward and saying, actually, you haven't done those ops. And we've been really robust around the clarity and the boundaries about what's acceptable, what's unacceptable, and the expectations. So the falsifications are from those hourly observations and those intermittent. Pushing the button, saying you've done it, and you haven't. There is a consequence to that, because that is a red line. That's not about being late with your observations. It's about being disingenuous, isn't it? Saying you've done something and you haven't. And we've been really clear that that constitutes a disciplinary process. Because you have to have a boundary, don't you? And we can't have people saying they're doing something and they're not doing something, because what else are they saying that they've done? And again, going back to the culture should be, it's an absolute privilege to spend time with patients. It's an absolute privilege to be part, albeit a small part, of their recovery. And we have to be clear about the kind of the parameters of that. Does that answer the question? Thank you.
And yes, it does answer the question, and I think that's quite important for us to know what that actually means, because it can conjure up all kinds of images in your head of what those falsifying records are, and it's good that you're dealing with that. And obviously I would ask that is a real drive forward, and I know that you've said that because the outcomes will be somewhat difficult. With regards to the treatment of the perpetrator of what happened in June, it says in this report that it's not been published as to the report. At the time of writing, the report into the treatment of Aldo Calocane has not been published yet. When that is published, is that a public document? And will you see that before the public does, would be the question. With regards, I don't want to talk too much about this, just a simple answer. Just because it is in this report, and I would feel really bad as a counsellor if I didn't mention this, since it was in the report. I would have preferred this not to be in the report personally, but as it is in the report, because I think it's a completely separate conversation, to be honest, and something that requires a lot more in-depth conversation and respect towards those victims. But seems as it is, I feel compelled to mention that. So if we as a committee at some point could have some clarity of when that is going to be published and whether we will be receiving that directly, that would be really helpful. Thank you.
So again, let me be clear and be clear that it's mentioned in our report because it was part of the original terms of the Section 48. So it would be we wouldn't be giving you a full picture if we didn't mention that. So as I was saying earlier, so there are 2 reports that are being written into the detail of what happened into the care and treatment of Aldo Calocane. One of them is the first part of the Section 48, which is a review of available evidence and a review of some other individuals as well within the county. So this is the review that I was saying hasn't involved the CQ, and this has been carried out by the CQC and This hasn't involved the CQC talking to our staff to triangulate the information that is out there. We anticipate that being published towards the end of June. And I certainly hope that we will. Did I say June?
Yeah.
I did, yeah. And we certainly hope that we will see it as an organisation, because it's a CQC report. So their processes are that they're meant to share it with us for factual accuracy prior to that. So I do hope that we will get to see it in advance of that publication date. And it is then, yes, it will be a public document. And so on the date that it's released into the public by the CQC. There is a second, more detailed report, which is the independent, not done by the CQC, but an independent group of specialists carrying out an independent homicide review. That is the normal process when a tragic event like this happens in the country. If I'm honest, it's the one that we get most of our learning from. It's the one that interviews staff and clinicians involved in the case, looks at records, talks to leaders, understands processes. So it looks at wider causality, wider factors that might have contributed to the event. I don't think we're clear when that work has started. That work is ongoing. I think it will be published towards the end of the summer, probably. But just a note of warning is that my experience of these sorts of reports is that they often get delayed because they're seeking more and more detail. So there are two reports. Both will be public.
Nigel.
It is now. 50 years now, it goes full cycle. I used to transport patients from Rampton around the country as a copper. I want to speak in terms of Rampton, and it appears that there are issues with staffing, patients, culture, concerns over leadership, and we've got employees there, we've got people that manage there. So are those same people that led the team still there? If so, they have contracts of employment, they have current terms and conditions on their employment? Has there been any disciplinary, any dismissals, anything of that nature? And just on culture is certainly reflective of leadership. So, yeah, that's my question. Thank you.
So there are multiple reasons. So again, for the visit to Rampton, we're going back a while, and since then there have been reorganisations. We have put a different structure in place, and we have wrapped more what I would say called corporate support, so more support from agency or parts of the organisation outside of Rampton into Rampton to support those leaders and managers. I don't think it's appropriate for me to talk in a public setting about what's happened to individuals. We take the report really, really seriously. One of the things that we're working really hard at is helping our managers and leaders to have a voice in the improvement, but also to recognise their part in the outcomes that we've got, and what they could. This goes back to the learning culture, what they could have done differently, what they should have done differently, what they will do differently going forward. And I think every single leader and manager in the organisation, including the three of us that are sitting here, need to be having those conversations and are having those conversations. Culture does that. You are absolutely right. Culture comes from all sorts of parts within a team, but leadership is one of the biggest things that propel a culture either to improve or to deteriorate. We are really, really clear about that, really mindful of that, and that is part of our expectation of the leadership at Rampton leadership across our organisation actually going forwards.
Yeah, thank you, Chair. Thank you very much for your report this morning and if your letters that have been coming through with the emails. It is very helpful, and I do think as a county council we haven't really engaged enough with your service when you talk about the vast complexity of it. 10,000 staff, 2 hospitals, all that involvement with SEND, and all the mental health stuff that you do. And I think it's greater interaction with councillors probably would help going forward. And I say that, from one end of the spectrum to the other, because my father-in-law was a caretaker of a school. My son is a student at Nottingham Uni. So that's the passion behind the people that come to this room. So what I'd like to get to the bottom of really is although you've got 85% of your services are running great and they haven't hit the media for obvious reasons. You talked about your recovery, your phase plan, that there. So if we talk about that, because obviously that is the root cause, and you saying to us that this time, for the first time in years, you've gone into deficit, and I'd like you to explain, or if you can't do it today, come back with your proposed recovery plan, because for me that's a bit like a vortex. That means we don't advertise for staff, and then we use agency, and that costs more. And when we've got staff voids, we've got pressure on other staff, and that's an endemic problem. It's just one thing to another, and I'd like to understand, or try to understand, how you came to have that deficit at such a level. Was there a specific cause for that? Are you addressing it? And there's a few questions, but the other thing is the reliance on private healthcare beds, and of course, I'm assuming that with the reliance on private healthcare beds for mental health patients, with that comes private staff as well. Or do you send your own people in? Because that's another quadrupling of expenses, because they'll overpopulate and keep them longer. So it's a spiraling problem, isn't it? And I do think, and the last time I remember your trust coming in here was when Rampton had a CQC report that wasn't very good around 2018. And we all had a site visit to Rampton. It was very good, actually. Some of us didn't come out. It was very good, and it was very interesting, and I think it gives a greater insight to councillors on what you're actually doing, because it's very hard for us as laymen to come in here and sit and criticise you as an organisation of such vast complexity. And I know you've got fingers all over the place, and there are many other facets that you deal with that we're not aware of. And I think that might be another one, perhaps potentially for adult health and social care. I'm the vice chairman of that committee, but it might be a good thing going forward, considering what's happened. That you came in and you explained your organisation more and helped the council understand it, because I do think you benefit from the interaction, and it's a huge thing when people say you're not communicating with your staff. You've got 10,000 of them. That's a hard task in itself, isn't it? So I think we could be a critical ally, is what I'm saying, and I think a greater interaction between the county council's health scrutiny or adult health and social care going forward would be a much more productive way of dealing with it. It would also allow us to scrutinise certain elements that have come to light, after. And I'm glad to hear that the independent report is of more value to you, because it scrutinises. So you're going to find out what went wrong and what went right from that equally. And I think that's a good process, and I think we could be part of that process as well. So really my questions are about the financial deficit and how your recovery plan is going to solve that problem, because that's at the beginning of everything that could potentially be going wrong from now on. And can you allay our fears that you're not going to rely on an overusage of
staff from agency, because that's part of the problem. I know it's not been easy over the last few years to recruit staff, but we do have the bursaries and the universities here, so you've got that wealth of people that you could be using for training and changing your culture as part of that. Because the other side with the NHS is when people get to sort of like my age, they retire, don't they, or they go into part time. I mean, the hospitals have been doing quite well of getting people to come back part time, because there's a lot of knowledge with that transition, isn't there? So sorry if there's a lot going off there, but that's why you need to come back again, I think, because we need to ferment this relationship, because it can only be beneficial to both sides. Thank you, Chair.
So I totally agree with you. I'll bring Jan in to talk about the plan. I suppose I just wanted to reinforce the fact that I think both components of that report are going to be really valuable. So I think the CQC third section of the section 48, there'll be learnings in that, and we will accept. I can say that now, we will accept the recommendations in that report and work to do those, and the independent homicide review, equally very, very valuable. If I just mention the drivers of the deficit, and then maybe you pick up the plan. So for us, the deficit was driven last year predominantly by three things. One of them was those out of area placements. So more people needing bedded care than we had beds for within Nottinghamshire, and that's an expensive business. And so that drove the deficit. You also correctly identified agency as being something that is very costly, and that also drove our deficit, along with maybe us not delivering some of the efficiencies that we said we were going to deliver. And I think those were the three reasons. I think finance is a part of this, because you can't separate finance and quality. The two do go hand in hand. I think it's really important that we recognise that, which is why, Jan, it's part of our plan, isn't it?
Thank you very much. And I really take from what you said at the beginning about what this means to people. I live a couple of streets away from where Ian Coates was killed, so I walk my dog regularly past that spot. It really means something to us as well, and I just wanted to say our staff live in the communities as well, and so it's so important we really understand the importance to our communities of us being able to address some of the issues that we need to address, or all of the issues that we need to address. In terms of the plan, I mentioned that there is a finance and productivity programme within the plan. The immediate focus, I would say, is on that private sector beds. Yes, it is private sector staff, because what we do when people go into private sector beds, some of which are within Nottingham and Nottinghamshire, some of which are out of Nottingham and Nottinghamshire, is that the private sector company then takes over the care of that person. We have that quality oversight that Di talked about. We keep that contact, but basically they staff it with their own staff. They have their own registration, they have their own inspection regime, their own regulation, but they staff it, and we keep that quality oversight. It's not where we want to be, because it is costing us more money, and also we don't have as strong a quality oversight as we will have of people being in our own beds, and particularly we want to avoid people being out of area. So it is absolutely the focus of our programme, but there are some longer term things that Ifti mentioned as well. When we look back, we can see that deficit has been kind of a storm waiting to happen for the last 5 or 6 years, and probably a little bit masked by having some non-recurrent funding, by what happened during COVID. And so what we really need to address is, why is that the case? Which of our services are not actually getting the income that's needed to run the services in the way that we're running them, and what can we do to run them in a more efficient and effective way? And some of that might be breaking down some of those silos that Ifti talked about. Some of it might be really looking at longer term, changing some of the pathways of care. We're not going to do that in the immediate term, because we've got enough on our plate to tackle those immediate quality concerns and those immediate driving down the usage of out of area beds, etc. But we do know that we need to relook at how we deliver our services across the piece and really think about transformation, and that's what's in the plan. It just struck me when you were talking, because Ifti mentioned the 2 hospitals we have in terms of community health. overall, I think the trust has 10 hospitals that we run, and probably that's something that not everybody is aware of. And one of the things that I do sometimes is do talk to our new governors when our new governors start. Councillor Doddy from the County Council is one of our governors. And it's quite a useful little presentation around what our organisation delivers, what it's all about, and that fact that we deliver local, regional, national services. And if at any stage that briefing would be of help to councillors around this table, I'd be very happy to offer that as a briefing session and just come along and just help people to build that understanding of our organisation. Thank you.
Yeah, if I can come back. Yeah, I think it's a very fine balance, because you've got to be risk averse with certain patients and pathways, and that's another problem, isn't it? But I do think that that explosion in out of area beds is what's caught you by the tail, isn't it, really? And I don't want it to become a cascading problem going forward. That's why I'm asking about the finance, because that's the bedrock of what you do, isn't it? And I do think we'll have to bring you back to one of the committees. I'm not sure which one. Noel will tell us, but we can talk about that in the work programme at the end. But I think it would be a much more helpful structure, a reciprocal conversation about where you're going and where you're at, because you're a much more complicated organisation than people take the face value of, aren't they? Thank you.
I'll address that point at the end, David. That's okay. That one. So, Eric.
Yes, thank you, Chairman. I'm substituting today, so I've not really had a lot of history behind what you do, but I do have history quite a long time ago when we had a police authority, stuff like that. So I got involved at Marax, for example, the early morning meeting, and so I'm really interested in that. And that shows really that we're focusing on your organisation here today, but actually it's a wider thing, because you have the partnership working, other people you need to have information from to help you make the right decisions to serve your patients and the community and families around them. So my question is about the triage that I mentioned earlier on, and the risk assessments. How do you assess the quality of the triage and risk assessment process, and therefore you're getting the right results for managing that patient care going through the system and the process? And you talked about it's not been a system thing. You look wider to the individual needs of those people that you're working with. So how do you assess what that improvement is? And when you come with an improvement plan, you know that you're doing the right things that actually produce the results. I think that's really it. I think most of the other questions I'm going to ask have been answered. Thank you.
Thank you. Can I give you an example of that? So in our crisis teams, we reviewed all of the risk assessments. So that is that risk assessment when people are first referred. And we are now 100% compliant with that. So we have a monthly audit of those risk assessments in crisis. And it's not just looking at are they in place, it's looking at the quality of them. And actually our safeguarding team have been instrumental in those audits, because we want to ensure that risk incorporates absolutely everything, that we're not one-dimensional, and we're thinking about kind of families and social risk, physical risk, all the risks. So the other thing that we've done where we can really dig deeper into quality is we have risk assessment meetings in all of our local mental health teams and our crisis teams. Our nurse consultant for suicide prevention and self-harm has been attending all of those risk assessment management meetings and listening to the quality of the conversation and triangulating that into what's in those risk assessments. And so I think that measuring the quality is twofold. One is about those formal audits, not interviews, sorry, but the other is about that visibility and presence of experts and leaders in those meetings and thinking about that, the quality of the conversation, and then does that then go into the risk management or safety plan? Because you can have the best risk assessment in the world, can't you? But if it's not owned by that person and their family and their friends, and it's not put into a safety plan, it's hardly worth the paper it's written on. So that has been the format. the other really important part, and this is the bit we're developing further, is going back to the person and saying, did that risk assessment represent your risks, your needs? Because I truly believe that good risk assessments, the people who are unwell know their risks and they know what works for them, and it must incorporate that as well. So series of audits, presence, visibility and team meetings.
Can I just come back on? So the other word that I didn't say, what I meant to say, was that the key to help people is to help prevent escalation. So how do you build that into the system?
Yeah, I'll start, and others might want to link in. I think that early detection, early prevention and early intervention, absolutely important. It goes back to other colleagues' kind of questions and comments. If you can help people early on in their pathway, we know that the amount of time they spend in the more higher end of the pathway is less. So I think that's the importance of our links with our GPs. So we do have some primary liaison nurses. We are working in our GP surgeries. Our liaison service is good. But also, I think the third sector, voluntary sector, plays such an important role in this, and how we navigate services, because not everybody will need to have their interventions with us. But we are continuing to strengthen those relationships in GP surgeries, which I think is going to be really, really important. I don't know if anybody wanted to add anything.
Yeah, I'll just add a couple of bits to that. So one of the recommendations from the Section 48 review was that we have a protocol with each of the primary care providers, and so what we do have a group now, we led by we employ within the trust as an associate medical director, a GP, and he leads a group where we liaise with GPs across the whole city and county. Through that group, we're going to be developing those protocols. We'll probably do it on a primary care network basis and make sure that we get that in place. And then on the third sector, just to say, for the past few months, I've been running a third sector group, inviting along third sector organisations to come and work with us and talk to us about how we can work together much better and how we can deliver services. And some of that would be, we do indeed commission the third sector and we pay them to do parts of the pathway in the way that Di described. Some of it would just be about connectivity and having making sure that we really understand each other. And I think the next stage of that work will be to really engage a wider group of staff in that, so that not only are we looking at that from a sort of trust-wide basis, but we've got that really deeply into our services, so our staff are really understanding what's out there and how they can work better with the third sector.
Right, thank you, Rach. So thank you very much for all those answers. I think obviously it's been a long item, but I actually think it was needed because of how serious this obviously impacts across all of Nottinghamshire. And I think the committee today is, to me, asked the one raised question. We got the answers from you, which form basis where we need to go going forwards. And as we mentioned a couple of times before, myself, Noel, and Bethan did actually meet before, and we're talking about the recommendations in terms of asking to come back in around 6 months' time, because I actually think it'd be really important to understand, especially with the development of these reports going forward and potentially the other reports coming forward, to understand. But also, although it's really welcome what you've said today in terms of what you are aiming to do and what you're looking to do at the minute, I think for the committee is understanding as that actually transpired into actions, because that's what we need to be able to justify to residents of Nottinghamshire that actually work is taking place and it's going to change going forward. So that's what I put forward to the committee. Would everyone be happy with that as a committee, that we amend the recommendations to bring this back in 6 months' time? Okay, so two recommendations. This is why I didn't do them at the start. I'll consider some comments on the attached briefing, which everyone has, and very much welcome to everyone for their contributions, and considered how and when it wishes to receive further updates. So for me, we'll just change recommendation 2 to ask for representatives to come back in approximately 6 months' time, depending on the work programme, to give a further update on the work being done to address the concerns in the CQC reports. Is that okay with everyone on that wording? Okay, thank you very much. So all in favour? That's unanimous. Thank you very much. So again, thank you very much for your time today. We appreciate it. I'm going to pause for 5 minutes, kind of aware of how long we've been. We've gotten it right, and everyone wants a quick comfort break, and then we'll reconvene. Thank you. Okay, so thank you everyone for that. We're going to crack on with agenda item 5, which is the access to elective surgery in Nottinghamshire. So thank you very much for Lucy and Lisa Jania for joining us today. So thank you for coming to present the report. Rather than me waffling on any longer, I'm going to bring you straight in. Thank you very much.
Thank you very much, Chair. So my understanding is that the committee has asked us to brief you on how our local hospitals are performing in addressing waiting times for diagnosis and treatment of planned care procedures. As you know, in line with the national position, a combination of COVID pressures and ongoing industrial action across a wide range of healthcare professions has unfortunately impacted on our hospital providers' capacity to see all of our patients as quickly as we would like. The paper that you've had sets out the detail of where we are now, how we plan to improve waiting times, and as importantly, how we're addressing patient safety and patient choice. And the appendix to the paper provides a summary of key data in relation to waiting times for diagnostics and also the key measure referral to treatment. So I'm very happy to take questions on the paper, but I was just going to pull out a few headlines by way of overview. So as members will be aware, the national target does remain a maximum of 18 weeks that anybody should wait from referral to treatment for planned care. Nationally, the position against that target, as the paper says, is 57.6%. We're delighted to say that Sherwood Forest Hospital, that runs Kingsmill and Newark Hospitals, is achieving 60.9%, so slightly above the national average. Unfortunately, Nottingham University Hospital, so City and Queen's campus, benchmark slightly under that 18-week target, but they are improving. The last 4 months' data we had said that they were achieving 54.3% of patients seen within that 18-week period. So there have been a range of challenges, and our local challenges are no different to the national ones. So we've had multiple periods of industrial action, also combined with unprecedented pressure on emergency care, and that has led to cancellations and also of planned care, and also less flexibility to reschedule. Looking ahead, however, we do have a trajectory for recovery. We do manage our waiting lists very, very carefully, and our plan is to ensure that we have no patients waiting over 78 weeks by the end of May. When you look at the waiting list, you will see that some patients are very complex, and to get those treated, we need the right combination of theatres, intensive care, and all that sort of support. And some patients do also choose to wait. So patients may choose to wait for treatment because of things like booked holidays, school holidays, or family commitments. But we are aiming to ensure that there are no patients waiting beyond 78 weeks by the end of May. The next target that we have to hit is no patients waiting beyond 65 weeks by September. And this was nationally originally March 2024, but it's now September. And no patients waiting more than 52 weeks, which is a year, by March 2025. Do you want to carry on? So we do manage our patients in all our specialties according to these trajectories. And just to mention, as the paper says, the biggest challenge that we have for long waits is down to sheer volumes in specialties like ear, nose and throat, and also trauma and orthopaedics. Just finishing a little bit on what we're trying to achieve, the diagnostic weights, we should have no more than 15% of our patients waiting over 6 weeks by April 2024, and that should be no more than 5% by April 2025. And we are, as the paper says, currently meeting those targets, with particular challenges with cardio echo at Sherwood Forest. So that's just setting the context of where we are. Probably more importantly, how are we addressing these challenges? So we've got a combination of short-term and longer-term measures. In the short term, we are trying to increase our capacity to carry out procedures through a range of different measures. So additional waiting lists at weekends, greater use of the independent sector. So the independent sector are commissioned to provide NHS care, and also bringing in what we call insourcing bringing in independent sector providers to assist the trust to do additional work within the trust to do additional work within their own capacity. So we continue to do that to create short-term capacity. We also have short-term capacity with additional community diagnostic space in both Mansfield and Newark. I'm sure some members will be aware of things like the mobile MRI in Newark, in Mansfield Town Centre, and there is mobile MRI at Platform 1 in the city. Longer term, however, we must be able to increase the number of patients we can diagnose and treat. And that will be through a combination of putting in extra physical capacity and improving productivity through new ways of working. So the sorts of things that we are going to do in the medium longer term, there will be a new community diagnostics facility, first phase at Mansfield Community Hospital, ready in April 2025, with its full capacity being available by July or August 2025. We're creating what's known as elective hubs, so ring-fence capacity, wards and theatres away from urgent emergency care pressures. Newark opened additional capacity last November, and the City Hospital campus in Nottingham has a phased development. We have 20 new elective beds open and 3 new theatres, and there is more theatre and ward capacity coming online at the City Hospital in 2025. And again, that is dedicated for planned care. That won't be impacted by emergency pressures. We are also increasing productivity through our theatres and outpatients, and we're aiming to be as close as we possibly can to the productivity measures in the national GIRFT, which is Getting It Right First Time programme. So really saying, are we delivering the maximum productivity we can with the theatres, the wards and the staff that we've got? We're also looking at making sure that patients who are having operations are as well as they can be pre-operatively, because we do know that if people are well prepared, they will have a shorter length of stay and they will also recover better. So that is a really important part of the work that we do. And with that, we've got anaesthetists working across primary and secondary care, and also supporting patients with multiple conditions so that when they have their operation, they have the best possible outcome and they can go home as quickly as possible and recover as well as possible. We are doing things like patient-initiated follow-up, so where there is no need and in fact no benefit from patients visiting hospital for outpatient follow-ups, giving people advice about when they should make contact if they feel that, but that frees up outpatient appointments to see new patients. We're supporting our GPs to offer advice and guidance to patients who may or may not need planned care, and we're also using digital tools to contact patients, but we recognise the issue of digital exclusion, so the digital tools will only be used where appropriate for patients, and Lisa can talk to you about that. So we are focusing on how we ensure that where patients are waiting, they aren't unduly affected by waiting, and that they remain supported and informed while they wait. Just finally, just to cover how we are ensuring that patients do wait safe and well. So we must ensure, and again this is a national, not just a local issue, that these longer waiting times do not exacerbate health inequalities, that those who wait longest must not be those already most differentially affected by deprivation and other exclusion lists. So that is really important to us. We can tell you that statistically, the proportion of wait over 52 weeks in those deprived populations is no greater than in other populations. So we don't feel, whilst everybody is waiting longer than we may want them to, we don't feel that there is no evidence, no statistical evidence that those that are most deprived are suffering longer waiting times. But we're not resting on our laurels. We do review our waiting lists, and again, Lisa can talk to you. We're doing a piece of work looking at when people are attending the emergency department, just checking that their admissions or attendances at the emergency department aren't related to a planned care procedure that they may be waiting for. So we continue to keep a real eye on Patient safety is incredibly important, so our trust do now use the patient safety information framework, so that we make sure that where we've got patients waiting long times, we do look at any potential for harm, and we review all our patients on that basis. And again, there is so every patient waiting a long time is reviewed, and we do not currently have any evidence of significant harm due to long waits, but that's work that continues day in, day out. Finally, on the direct impact on patients, we do have an obligation to ensure that all patients are offered a choice of provider where that choice exists and it's clinically appropriate, and that choice can be in Nottingham and Nottinghamshire, or it can be further afield. So we have to use all the capacity available to us for people to get the earliest possible treatment. So patients are offered choice at the point of referral, and at that point their potential wait times are explained. We do compare waiting lists at Sherwood Forest and NUH each week to arrange what we call mutual aid. So we want to sort of equalise our waits. So, for example, Sherwood Forest is supporting NUH with ENT capacity. NUH typically would do the more complex cancers. Sherwood Forest can do the less complex work, and in doing that, we can make sure that we equalise the waits between the two trusts. But mutual aid is something that we do constantly across all our waiting lists. We do use the independent sector. They do work with us on a weekly basis to offer additional capacity. You know, just to reiterate, it is NHS care funded at NHS rates, but they do have capacity, and patients will choose that capacity. And there was also a one-off exercise last October where we offered choice of provider to all patients waiting over 40 weeks. And we looked then at capacity within a 50-mile radius. We found 277 patients that we could offer capacity elsewhere, and we found capacity for 97 patients. And that did result in 70 patients being moved to another provider to get earlier treatment. So I think that's probably it from me. I would like to assure, hopefully not just reassure the committee, that we do continually seek to try and understand not just the size and shape of our waiting lists, but the impact on patients, so that we do use all the capacity and skilled professionals that we have to try to continue on our improvement journey. Thank you.
Yeah, thank you, Lucy, for your time presented there. I mean, you're absolutely right. The reason it was asked to come forward to committee, I think it was Beth, you introduced in your work programme, was because it's all very clear in the press about the impact we said about the strikes, and with the pressures that the service facing, as you've mentioned yourself in reports. We just wanted to understand what that impact was having overall in terms of what the picture was looking like. So we should present it forward today. So I was conscious that John's got time pressure before he needs to go, so I'll bring him first. I'll come back at the end. John.
Thank you very much, Chairman. Thank you for your support.
There's a point of order or just to go on the list, Michelle. Sorry. Yeah, okay, we've got you now.
I say thank you very much for your report. Waiting times for surgeries have been a problem for many years, and improving performance is going to be very difficult. This has been exacerbated by the COVID pandemic, but we just cannot just blame that. The report says that elective surgery has been impacted by industrial action by nurses, junior doctors, consultants and radiographers. But much of the problem is overwork as well as remuneration. So once again, workloads need to be reduced to effectively work out the problem. So you come to the same old problem. Work out the cause of the problem areas before surgery is required. That means not living life to its extreme. It's all right setting targets, but it will be difficult to improve waiting times at hospitals, and many people coming to this country have different clinical issues that will need addressing. So my point is early intervention schemes must become a priority. It's to help keeping people well so they do not require the surgery, if you understand what I'm trying to say. Obesity, heart and other main organ problems can be improved with the change in lifestyle. It's it's absolutely essential that more scans are available. It's now over £400 to have a main scan at a private hospital. If they became more, acceptable, that people would if they wanted one, or they felt ill, or the surgery needed that person to be done urgently, it would be unacceptable not to do that. And as I say, in the long run, it's going to cost a lot of money. I understand that we're putting all the equipment, buying all the equipment, but it would save money in the long run because of the amount of people that won't need the surgery. And small ops must be made available at surgeries. To try and stop some of the overwork that's happening at the main hospitals. It's a great change that I'm talking about. It would mean a complete reorganisation of the system. Yes, it's difficult. It would be difficult, but it's not impossible. Thank you.
Okay, thank you, John. I mean, I've seen you made a lot of points then. I'm sure you can appreciate Lucy can't address all of those, and I wouldn't expect her to. But we do take that on board. And so I think the early intervention, especially key, so we can talk about that, Lucy, please.
Yes, absolutely. I mean, I think, Councillor Wilmot, your passion for prevention comes out, in everything that you say, and you're really, particularly at Health and Wellbeing Board, and we would absolutely agree. Avoiding people needing any form of care, be it emergency care or planned care, is better than treating it. So we will remain very much focused on prevention and early intervention. We do, I mean, I don't know whether now's the time, but there is a lot of work going on around personalised care. So when somebody might get referred from their GP onto an elective waiting list, reviewing them to say, actually, is this surgery the right thing for you? Can we be, what are your personal goals? Because we know that not all surgery necessarily helps people achieve their personal goals, but saying, if you are going to have this surgery, you need to be as well as you possibly can, and as I said, you will recover better. So I think we are really working on this sort of patient-informed decision making and prevention. I think the diagnostics, I would just note that as a county, as a city and county, we have really benefited. We are having 2 community diagnostic centres, and that is down to the work of our colleagues, in the ICB and the providers, making sure that we put in really good business cases. So there will be more diagnostic capacity. So that is a good thing. Nottingham and Nottinghamshire does very well. I think your comments about minor procedures in GP practices, I think what is probably more important, we need to make sure that people are cared for in the right setting. And I'm not sure that GP surgeries or indeed GPs are necessarily best equipped to perform many surgical procedures. But what I would say is that we are doing really, really well, around things being done as a day case. That many years ago, I've personally benefited from having both my cataracts done, and really it was just like going to the dentist. You're in, you're out. Many years ago that would have been an inpatient stay. And so I think both hospitals work really well on improving day case, and that means that we get much more work done. People are much less affected by having to have major surgery. So I think your points are all well made, and they're all things that we are very much focused on. I do think, however, that there is a productivity opportunity. I don't think it's just about overwork. I think there is something about us organising ourselves to be as productive as we can. Sorry, Lisa.
Yeah, I can just add to that as well. So we've been working on a programme across primary, community, secondary care about optimising patients who are on an existing waiting list. So a key part of that work programme is about having an early health screening tool in place, so we can support patients from day one when they are put on a waiting list, understand what matters to that patient, but also pulling in the health information that primary care will collect. The community teams will be how they're managing patients around diabetes, whether it's weight management, whatever it is that patient needs. So we are able to optimise that patient as early as possible, so we're not potentially waiting quite close to a surgery date to then identify that that patient might need more. So it's just to add to reassure you that work's about to kick off, and there'll be some early health screening tool, I believe started from June at NUH, and SFH is just got a tool that's a bit further behind, but we're going to be on it this year.
David. Yeah, thank you. Obviously, we knew there was going to be a tsunami of elective surgery after COVID. That was obvious, wasn't it? Plus, as well, with the NHS's ability to cure more patients from various things, and hopefully Ashfield's lifespans will stretch to Rushcliffe's at one time. But you know, we can all be hopeful. I'm going to stick with the positives, and I think it's great news. I'm presuming all this work at Newark is coming from the 5 million you got the other year, you know, for the improvements there. Can I just ask you one question about Newark? I know I keep fixating on it, but it seems we're never going to get it at A&E. But is there a primary care hub at Newark?
Sorry, depends what you define primary care hub. So there is an urgent treatment centre.
Lucy, sorry, you just want your microphone again.
Sorry, it's the same thing. Sorry, Councillor Martin. So the PC24 at Kingsmill is exactly that. It's open 24 hours a day, but you are able to turn up with an urgent care need and be treated. So not an emergency care need. That's exactly the same as is provided at Newark. But it's not a primary care hub. We wouldn't be encouraging people to go to Newark or Kingsmill if they could see their GP. But if you do have an urgent care need, it's not an emergency care need, those facilities exist on both those sites.
Sorry, I digressed there, Chair, but I was just asking the question. The community diagnostic centres, are they mobile? Because obviously I don't see one in the list at Newark, but also I think those mobile units are quite good, very effective, because they take it to population centres away from A&Es, like you're saying. Do the city council know that there's one open in Broadmarsh?
So yes. So in answer to your question, you're right. Mobile screening is something else we haven't. So you'll have heard about things like targeted lung health checks, where we actually take the screening capacity to the population where we know there is a high prevalence of smoking-related diseases, for example, and we'll carry on doing that. The community diagnostics centres that the government has funded are not mobile. These are permanent facilities where people can choose to go and get a range of scans. It will increase to the full range of scans or diagnostic interventions. They will be permanent facilities. There is you're right at the moment. While we wait for those to be physically built, I think it's July next year that Mansfield finishes, and sometime after that the Broadmarsh will be built. There are pockets of there are mobile facilities at the moment. So, but you'll have 2 proper community diagnostic centres, and we will continue, no doubt, to provide mobile diagnostics for particular needs.
More, Chair. The only other thing is as well, I thought as part of the ICB that Bassett Law was included in Nottinghamshire now, for health purposes, and I don't see that before these two jump in. I don't see anything in your list for Bassett Law, so
very, very astute, Councillor Martin, and that so we do very much ensure that care for patients in Bassett Law is appropriate and meets our commissioning guidelines. It is provided, as you know, most of the inpatient care is through hospitals that aren't on our patch. But you are right, that is probably an omission in this paper. However, Lisa can talk to you about some stuff that we're doing around eye health, particularly for patients in Bassett Law.
Yes, we're actually utilising Bassett Law as the initial pilot site for a wet A&D accelerator project. So what that's doing is building upon the primary care eye care services community ophthalmology service that is there, which works alongside local optometrists to deliver sort of early health screening, prevent any activity going to DBTH that doesn't need to. So we're working with them about how we screen patients who are suspected for wet AMD, which is a really high risk condition. So that's going to be started in Bassett Law, and it will then hopefully then roll out to the wider ICS if it's proved to be successful. But of course, with Basset Law patients, we work across all place-based partnerships in the work that we do. So in terms of pathways, we always work alongside our Basset Law teams just to reassure this committee.
But I think it is a fair point. If we came back again, we could, whilst we don't directly commission those services ourselves, they are provided to our population, and we do make sure that they are appropriate to need. But we would include data from those two hospitals.
Okay, thank you very much, Steve.
Thank you. Just Lucy, I would say I'm very assured by what you've said, and that is quite significant because I got a bit grumpy in the last item. I was interested to say about GPs, and I'll share something. A big shout out to my GP surgery, Bramcote Village Surgery. I went in with a cough on the 3rd of April, walked away with a referral to dermatology, and on the 29th of April I had 2 operations in the GP surgery by the GP that spotted the melanoma, basically, too. And I had the surgery there, the same GP, and I think that is a big way forward, I think. So that was from being diagnosed, it was 2 weeks before I had the operation, and that is a fantastic service. And I can see that the efforts that you and your team are putting in will result in the desired effect.
It's reassuring to hear, actually, because that's clearly an intervention that GP could have in their surgery. So thank you for that.
Yeah, and thank you, Steve, for sharing that. I think it's really important sometimes to put the human face on it, and also to actually say the positive experiences, because sometimes we might feel we just want to explore what might be neither proven for the else, but it's really important to highlight that. And obviously, I hope you're a bit better now and on recovery. Thank you very much. Yeah, of course.
Can we have some sort of campaign? It used to be all over the place about putting sun cream on, and people put sun cream on when they go abroad, but they don't do it when they're in this country. When I was in Australia a couple of years ago, it was everywhere about putting sun cream on, and I know that doctors, GPs, find it very, very frustrating that people don't, and it's very expensive.
Yeah, I'm sure something to take away the word comments with Alex and Co and look at something. I think it's a really important point. Yeah, thank you, Steve. Thank you very much. Michelle.
I'm laughing to myself actually because this is a bit of a confession, and I digress slowly. But my son came home yesterday and said that I was in trouble with his teacher because I hadn't put a hat in his bag, and I thought, oh my god! And I was just thinking, it used to be everywhere, didn't it? What was it? Something, wasn't it? And I was just laughing to myself about what a terrible mother I was because I didn't give him a hat yesterday. Sorry. So I'm going to talk about health inequalities, which probably doesn't come as any surprise to me, and I come with the hat with regards to something that I feel quite passionately about, having worked on it previously in another area of the country. And in the report on page 3, where it says about patient choice, thinking about me being a terrible parent still, sorry. Patient choice, it says waiting for elective care could potentially drive health inequalities. I have a different outlook on that, in that elective care does drive health inequalities, and I'll say that for a number of reasons. First of all, there are certain health issues that affect areas of Nottinghamshire more than different areas of Nottinghamshire. We still have that near enough 8 years difference of life expectancy between the south of the county and the north county. And if you look at health and lung problems in particular, the north of county has significantly more people with those issues. So when you already have those health inequalities there in the first place, when you talk about elective surgery, if there are more people from disadvantaged backgrounds with a certain health issue and they are waiting longer, that will drive health inequalities between the north of the county and the south of the county. And that is something that is happening nationally, not just here in Nottinghamshire. The other element with regards to health inequalities that, again, is quite apparent at the moment, and this was a conversation I was only having the other day, 2 people on a waiting list for an operation. One person can afford to go private because they have a lot of money. Another person that doesn't have a lot of money cannot afford to go private. That person that has a lot of money pays for it, that poorer person doesn't and remains on that list. That drives health inequalities up because it becomes a two-tier system. If you can pay, you get the healthcare, and if you don't pay, you're stuck on a waiting list. And that's what's happening as well across Nottinghamshire for various things. In particular, ear, nose and throat, I've heard has got a particular problem at the moment. Just to go back as well, anecdotally, my father had a procedure cancelled, and when we were told it was cancelled, it's bad and it's urgent, but it's not as urgent as some of those other people that come in. So you're waiting. My mum got a text message the other week, and I didn't realise that this happened, saying it was about her appointment, to have her elective surgery, to follow a link, and the link was asking her whether she still wanted it or not and whether she was still ill enough. That's how long it has been that she has been waiting for that elective surgery. So when we look at these percentages and we talk about industrial action, which I won't go into too much because that would bring politics into it, but what I will say, these people are taking industrial action for a reason, and actually there are before any of that industrial action happened, there were over 8 million people on a waiting list in this country. And that's one of the reasons that they were taking industrial action. So I'm not defending it all, but what I'm saying is we have to look at this the root cause of all of this. Where has all of this come from? And I would say it's a total neglect of the NHS. And that's my thing. If no one would have mentioned industrial action, I wouldn't have got that far without it. But people have. And I feel it's only right that I say something with regards to that. But I do feel real passionately about that this report, for me, is incorrect. Waiting for elective care does not potentially drive health inequalities. It drives health inequalities for the reasons that I've stated. And when we're talking about Nottinghamshire, that's really clear. And I hate to be proven wrong, but in a year's time, when we do that analysis about life expectancy again, and where is that greatest need for the high-end, costly health services, I can guarantee you now it will be in the most disadvantaged areas in this county. It'll be up in Ollerton, it will be up even in Hucknall, it will be in Bilsthorpe, it will be in Rennes. All of those places already have those massive health inequalities. Mansfield, which I know Councillor Reddy does work up there, she will know what those health inequalities are like up there. They will get greater. It will get greater, and that's it. I'm not even nogging about it. You can say your piece. Well, yeah, that haven't been treated and that haven't been treated. Yes, it is, but that doesn't mean it doesn't drive those health inequalities. Okay, I'm not arguing with you about it. This is my own opinion. I'm not here to have a discussion about it, and I'll just have to ask if that's the case, Councillor Turner. So because you work in an industry, you should wait for your healthcare, and you should leave a shorter life because of the industry that you live in. What an that I'm afraid that's pretty shameful what you've just said. It's shameful. It's not just fact. It is not just fact. It's not just fact. No, it's not.
Look, can we keep it to the point, Michelle? Are you done? Michelle? Okay.
Health inequalities exist for a lot of reasons, and I hate to educate you, Councillor Turner, but the biggest driver of health inequalities is poverty, and that is fact. The biggest driver of how health inequalities occur is poverty. And
look, yeah, we've not
I've never had an argument with
keep it to the paper and what we can actually address here today. I agree.
So it is. Patient 5 is what I say. I disagree with what is in this report, that waiting for elective care potentially drives health inequalities. What I would say is that it is exacerbating health inequalities, and it continues to exacerbate health inequalities across Nottinghamshire. People are waiting far too long, and there has to be a whole-scale change as to how we deal with this.
Okay, so I mean, just before I bring Lucy in, because I still want Lucy to have to get involved in politics of it or policy that's not under the remit of the ICB. I mean, just to clear action, anyone watching when we talk about industrial action, no one here, we're not bringing politics about the merits of industrial action, but it's a matter of fact. If someone is not there to do surgery and it's cancelled, it's going to increase waiting times. We're not here to talk about the reason strike actually taken. That's why it's mentioned in the report, and I understand why, my colleagues, because it's a factor, and it's something that's directly out of the ICB's control, but it's about putting that in there to give some explanation. And about health inequality, I think we've been very much clear as a committee that it's something we want to address, but it's not right that people have different life expectancies. Part of Nottinghamshire, in my view, it's not. That's from being an area which has the highest. I still think we've got to work on that, and everyone will have different ideas where that health inequality is. We've seen the data. We know predominantly is in the north of the county. But I think what's absolutely clear is everyone in Nottinghamshire deserves access to the best quality health care that they can, and that's something that we are as a committee working to do our bit to make sure that happens. I know colleagues are ISB as well, which is something we'll keep doing. So thank you for that. Lucy, points that you can address. Thank you.
Yeah, I think just to say, Councillor Walsh, there is no doubt that the single biggest mission of the Integrated Care Board is to close that differential. The difference in outcomes between our least and most advantaged citizens, and we do recognise, and we have that data at a very, very micro level, and we can see where different aspects of how people are able to live their life does impact on their life prospects and their life expectancy, and we, I'm absolutely convinced that is an area of focus. I suppose the question about elective waiting longer, you are absolutely right, can make that worse. So our job is to say, if you take two patients waiting for the same procedure, who have different sets of circumstances, will we make sure that the one that will benefit greatest will be treated most quickly? That is what we have to do. That is what we have to do. And we have to look at our weights and say, it doesn't necessarily matter how old somebody is, how long they've been on the list and all the rest, through the, what is the benefit how do we get them treated as quickly as possible? And that's what we try to do. And there is no evidence to suggest that people who live in more disadvantaged parts of the county are waiting longer. And so I think you're absolutely right. There is an underlying issue. The data says that, but I think we can say that for Nottinghamshire, our elective weights aren't making that worse, but we need to make it better. I couldn't agree with you more. I think you also, I would remind you that the NHS, it is free at the point of delivery, and at the point at which you present, your financial means make absolutely no difference to the healthcare that you get. And that's the NHS that I've worked in 35 years, and it's the only one I would ever want to work in, and I hope that continues. But yes, we realise, and I think that's why, Lisa can talk about it, Councillor Welsh, that's why we're doing this work, looking at, are people turning up at ED because of a delay in planned care procedures, because that's the sort of thing we need to understand. So I suppose I'm not wanting to split hairs. We have got an unacceptable difference in life expectancy as one measure. Are we doing things that will make it worse? We don't believe so, and we're really trying to make it better.
Thank you very much, Lisa, for that one. Bethany.
Thank you. This was something that I wanted to bring, just because looking at I think it was pre-agenda and it was on the news that morning. I was like, so I think it was a conversation we should have. Is there a reason ENT is such a high number for both of the trusts? And then also, Councillor Martin raised the COVID. What were the numbers beforehand? Just to put it in, what's the normal level of waiting if we didn't have all the other factors? How, just to put it in perspective, really, because it would be quite interesting to see what that would have been without COVID, I suppose. But as well as that, when we're looking at the levels, you have reassured me with the report that you're working towards it, but it's still a long wait, isn't it? Is there anything else we can do more to try and bring them down?
Yes, try and answer all three questions. Ear, nose and throat, it's a national issue reflected locally, and I think it's principally workforce, is that right? Yeah. So having the skilled surgeons effectively to treat patients. So that, it's no consolation, but that is the cause of that particular issue. We should remember that we did do well. 18 weeks is the longest you should wait from referral to treatment, and it's not that many years ago that was fairly consistently achieved, certainly at Nottingham actually, and perhaps slightly less at Kingsmill, but I think that is what we have to get back to. I don't have the figures to hand in terms of gross numbers of people waiting pre-COVID and post-COVID. Apologies, they are out there. I know they are out there. We could bring those figures back to you, but I think we've just got to we can do 18 weeks. I think the other thing is, you know, it hasn't just been COVID. It hasn't just been industrial action. We have seen unprecedented pressure on emergency care, which is why it's really important to create this ring-fenced capacity at City Campus, for example. At Newark Hospital is the same. Newark Hospital is not an emergency care hospital, so if you're having your planned procedure at Newark, you will go into Newark regardless of what might be happening at the peak of winter with emergencies. So this principle of separating emergency and elective care, I think, is a big part of getting us to where we need to be. But I would stick to saying it's 18 weeks is where we want to get back to.
No. Okay, so thank you very much for Lisa for presenting today. I think it was really useful. I think it's really important we understand that, and that the public do as well, that there are factors, but at the same time, not using them as any kind of excuse in case we want to get there and where we actually are on the two hospitals, because two hospital trust, so to speak. I think actually seeing the differential there. And I think the one key thing you talked about the mutual aid and trying to resource across, I mean, that also hopefully gives some reassurance about when we talk about helping the quality of certain areas of the county. That isn't just a case of just happen to be what your nearest hospital. There is that work done to try to balance it out to give that right impact to us all in Nottinghamshire. So thank you very much for that. So in terms of recommendations in front of us today, which I'll go back to the right page. So it says. So we've got that one. Too many pages. There we are. Right. So with two recommendations, whether we consider and comment on the attached briefing, and consider whether we further scrutiny of the issue is required, and if so, what form this might take. So, let me comment on two. I mean, for myself, at the moment, my feeling is we just have to keep monitoring in terms of what the other reports that we get, in terms of looking like we think this might be an item we want to come back to. I think, to me, that's answered a lot of the points that were raised. I think before we come in at that moment of time. And although we could I'd happily have this on each agenda to keep talking about, and also trying to balance out the other work. So, if the moment we say, for the moment we I know Lucy, you might say some other information you might have. If you do, that can be sent around the committee. That if that goes to Noel, we'll send that round to members to get that there. But we leave this at the moment. It's a case of we will keep it up to an eye on it for the work programme. Look at future times we feel it's relevant and necessary to come back at that time. Potentially around when we talk about helping equality a bit more and where that come in. Is that okay with everyone? So those two recommendations. Okay, thank you. So all in favour? Okay, that's carried. Thank you very much, and thank you for your time today. Thank you. So, Pauline, yes, sir. So, yep, thank you very much. Sorry, well, that's all a question. Oh, you pointed up there. I was going to say, I thought, hang on a minute. I thought it's a point of order. All right, okay. We're on home stretch. If you need to go, Pauline, feel free to. We're going to be 2 minutes, hopefully. Well, I'm in your hands. So, home stretch, promise. We're on the work programme now. So, looking at the future meetings. So, on the 18th of June, we've got the NUH briefing, which is updated fertility service, and lung health pathways to lung cancer, obviously based on what was discussed at one of the previous meetings about the fact we sort of already covered cancer, but not the lung cancer part, so obviously we want to bring that back as soon as. I have met with Don Ockenden along with Bethan a couple of weeks ago, which was really, really useful actually in terms of understanding where we're currently up to and what is currently being undertaken part of the review. And I did meet with Auntie May as well separately, just to ahead of their board meeting, just to again talk about where the NUH currently is, and to briefly just touch on the fact about what I believe the committee wants to discuss in June. So I think that's going to be a really positive item there. July NHS 1-1 service, and we've got here about Bassett Law mental health and the A&E development. What's included in that as well is there's been a recent CQC report at Bassett Law Hospital. It's important we look at that as well in the wider context of what we discussed. And in terms of A&E Village, unless something dramatically changes, our understanding is it's still being built. So that's basically the update. So I don't really want a paper and half an hour discussing that one at the current moment is at the right time. So with your indulgence, that would then happen. There's also just one thing I want to take. You may have noticed we just left Newark Hospital. Newark Hospital is still on there. We'll take that off for now. As we've already discussed, we'll look to bring that back in around 10-11 months' time to look at the impacts there and the other bits. So, Noel, is there anything else you want to add before we bring Steve?
Yes. I just had a couple of things just to add to that.
The first one is that members may be aware that the Adult Select Committee is going to be considering the suicide prevention strategy at its June meeting. And so rather than us scheduling separate consideration of suicide as an issue within the health forum, I think because it is a public health issue that we should await how that's considered there, and that if people from this committee wish to feed in comments or to channel their concerns to adults in the first instance, so we're not twin tracking the same item, I think that would be an appropriate approach. The other thing I would say is that the ICB have indicated that they may wish to bring a paper to a forthcoming meeting, possibly June, possibly July, on finance pressures of in the ICB. But I await definitive steer from the ICB on that.
I think it's really important to me to watch suicide prevention. I think we really should see what is covered in scrutiny first, like I say, at the June meeting and at the Adult Select Committee. And if members feel like that didn't cover the topic in the detail that we perhaps would like to look at with our outward focus, more inward focus, that's absolutely something we can look at on top of that. But we don't want to prejudge what's done at that scrutiny committee first. And I know some members on that committee as well from here, I'm sure, will be very used to there. But again, if any member here has anything they want to raise, please let me know. We can speak to chairman of that committee, and I'm sure feed information through to that. I'm sure that'd be welcomed, that one. And I think you're about the ICB. I think it's worth seeing what they want to present, but I think it's ICB obviously want to come to us present that, but it's up to the committee here if they feel like that's something they want to bring forward, and at time to understand where the pressures currently are, that might sort of influence where we are with the rest of the work programme. So myself, I think it'd be important to understand the context with the ICB currently looking at next year, because obviously that will have an impact when they're looking to transform services in certain ways, that impact will have on our priorities. So I think it's something we should look to bring back here. Look at June, it's quite packed already. July probably to me sounds a bit more sensible. Also, if they've not quite got the report ready yet, that's looking how tight the timescales are in July for them to put that together and consider the full ramifications and bring that here. Would everyone be okay with that as a premise? Okay, Steve?
I think next time's meeting is going to be very, very interesting and very important, given some of the things that we're hearing about maternity services. And we knew about them before, but it's getting worse. Anyway, apart from that, GP contracts is going to be a big issue. I'm hearing from a lot of GPs, particularly the ones in Beeston, that the new GP contract could be as detrimental to GP services as the dental contract was in the early 2000s. And I think we should perhaps be doing some investigating work and talking to GP organisations as to how they think that the new contract is going to affect them. Because you have to remember, GPs are like dentists. They're not. They are part of the NHS because they're commissioned by them, but they can do what dentists have done since 2000 and whatever it was, and just go private. And this is going to be a very, very serious issue coming up.
No, I understand, Steve. I think if we chat to the ICB colleagues first of all, understand where they currently are, what they could present and review to their understanding, and whether that's the right time now or where it has to be fit in the future, I think we'll absolutely put that on the discussion with them, just to understand where currently are, and come back to you the next meeting. That'd be okay. Thank you very much. Connor?
Thank you, Chairman. I'm just looking at the July items. I know we just discussed another one for that one. The NHS 111 service. I believe the additional performance data we requested was just regarding Nottinghamshire, wasn't it? And more specific response times within Nottinghamshire. I'm just conscious, could we make that a briefing note rather than an item for discussion? So then we can have the briefing note, and then once we've seen the actual data, if there's anything we want to pick up, then we can come back and put them forward. I'm just conscious in terms of timings, that July meeting could get quite hefty, essentially. So
I mean, I'll put in your hand if you feel that briefing note first of all, Michelle.
I've said this before, I think, so I apologise, but I really think when the maternity one is so huge. I'm not sure we should have something on the 18th of June on. I know this is getting slightly ridiculous because it just pushes everything else back, but I've got a feeling we'll be talking about that for a long time. You know,
Yeah.
the 18th of June, we've got two things on there, and I know I've said it first before, and I just think, given our experience with regards to this and talking about it in the past.
Yeah, no, I understand that. I mean, that's obviously, like you say, it's difficult because I'm always conscious that we just keep pushing down the line to work program there. And when our discussion with the NUH and obviously with Noel as well, in terms of report coming forward, it's more for the NUH to understand where they carry our up to in their journey of transforming maternity services based on the feedback from Donna Ockenden and the transformation work being undertaken by the Trust. Because although the report itself from Donna isn't going to be out till late next year, September time at the moment there, obviously very much clear that families want to know at the minute if they're going to be going to hospital service that it's safe and they're going to get the experience they want. So I think it's really important that as a committee we got that feedback. In terms of the report itself, in my mind, it wasn't going about in terms of everything to the review because obviously that's currently undergoing, and with that discussion, we don't look like we're predetermining any part of the review. It's more understanding at the moment what the maternity service provision currently is in terms of the quality being done, what has been learned so far, part of the journey with Donna and with the review, and and obviously the new leadership team that's been in place in terms of learnings they found so far, and where they are planning to be at the next few months. So that's why the reason I'm saying that is there. I don't think, and I'm cursing it here, aren't I? In terms of the actual length of the item, in terms of details going into it, it's not the full blown review of Donna's Ogden's review in terms of their overall service. It's more where the NUH currently are in their show there. So I completely get your point, Michelle. And like I say, could curse it if it gets to 2 o'clock and I was going, I told him it should have been quicker there. I'm just very much conscious, looking at the amount of items in the work program. If we keep putting just one item on there, we're going to push it wrong. So I'm in your hands to have the answer. It's the decision of the committee here. What you'd rather, if people are happy to. I mean, at the same time, what could be is you have the NUH brief. No, it's not there. It's no. I will reverse that. I was going to say that was too daft even for me. To put forward the idea that. So I've checked myself there. But in terms of where we currently are, in terms of that, are people happy? I completely take your point, Michelle. I really do, and it could be on there. Just where we kind of work program there. It could be determined on the day of the meeting whether the second item could potentially be, depending on the length of time going there, whether it's worth touch on it lightly, the second about the lung health, and looking at bring that back further, or with further information briefing notes. That's determined by how the item's going and the time taken. No, I don't know if you've got any view on that.
I do. No. I think just to remind people as well that at the June meeting, it will be the first meeting of 24-25 municipal year. So we will be revisiting the work programme and sort of rationalising what's on there to make sure that we're focused on what the committee wants to remain focused on. Just informally, I think, well, it's not informal if I'm saying it here, but there will be a challenge to provide the non-cancer lung treatment in terms of the scope of that report, and now that's been clarified exactly as to what it is we're looking for. It could be a stretch that comes to the June meeting, and therefore I think we'll have to come to some sort of conclusion back of house as to the art of the possible, I think, for the June meeting. But I'm conscious that there will be plenty to say on the maternity item. But no, it's difficult to be definitive on exactly what we can bring to the June meeting at this point.
Okay, so I think we could go around to this one. If we can keep it at the moment where we'll keep it under review, look at behind the, look at what we think the scope of review will be with the report coming forward, and see whether we believe that report could be done at the June meeting, depending on how long we think it's going to be in relation to the maternity review. And then with your indulgence, we'll look at potentially moving that if we feel like it could be too heavy an item on that day based on the NUH item. And is everyone happy with July with the 111 service additional data if we put that in the briefing notes instead, and then committee can determine whether they want to bring that back in any other form as well? Because as I think Callum made the point, it was additional data we asked for at the time. We sort of talked about the 111 service overall, which I think everyone put their feedback into where it currently was, but it was more that data to understand. So is that okay? Right. Okay. So we'll do that for now, and then if anyone has any thoughts on the work programme in terms of what should be on there in terms of prioritisation, please do feed that back into Noel, because obviously that's going to be looked at ahead of June as well, and look at how that works. And I think we're currently there. So just for me, just to say, you may have already seen the committee papers, depending on how it's all every Thursday goes. This will be my last meeting chairing the committee. So really want to say thank you to everyone for your support the last few months. It's actually really been a pleasure to chair it, because actually I think we covered some big important items. I do feel that working together, having everyone's different views has been really, really important to understand that. And we may have different political views outside the chamber, but actually I think in here and discussing the various items, hearing everyone's different thoughts, we've achieved a lot. So thank you very much, and obviously I'll continue to support the committee with my new role as well. And Roger, who will be subject to your votes on Thursday, taking over as chairman. So I'm sure you'll give him the same support you've given me, and obviously welcome to the role. And obviously, basically, my big thanks to you all, and especially Bethan for her support as vice chairman, to Noel and the officers as well. So we don't usually get to do that. We usually just get thrown out and you don't get the chance to say that. So I thought I'd take the opportunity. So thank you very much. Sorry, I thought you were. I'm choking about the tears myself, Nigel. Thank you. Sorry, Michelle.
Thank you, Jonathan, for all your hard work at this committee.
Thank you very much.
It's been great, actually. Great. Yeah.
Yeah, no, yeah. I would say short and sweet to the
You're
point.
a loss.
You're
a loss to this committee, but whatever you're doing, I'm sure you'll be very good at it.
Thank you very much. And like I say, I will continue to support the committee in new roles then, and I'm looking forward to much detail. So thank you very much, everyone, for that. And so if I was going to work programme, I'll continue the meeting closed and recording finished, and shall see you all soon in, 48 hours, I think. So see you then.